Thank you very much for watching
or
the video and
suspicions
for
about
that
sexual
word.
misconduct that
My
may
name is
occur
Ann
during this
Staples.
event,
I am with the U.S.
please report.
Centers for Disease Control and Prevention, and I have the honor of chairing this afternoon's session. And I'd like to start by introducing our respected guest, Dr. Patrick Abok, who is the acting WHO representative for Ethiopia. Dr. Abok.
Hello. Just confirm you can hear me? Loud and clear? Okay. Your Excellency, Mr. Lelisa Manuel, the Senior Advisor to the State Minister of Health of the Federal Republic of Ethiopia, the Secretariat of the Eye Strategy, under the leadership of Lawrence, the Associate Director and Chief of Immunization of UNICEF, Dr. Ephraim Limago, bilateral representatives from donor and partner agencies, colleagues, good afternoon, and a big welcome to Ethiopia. It's my pleasure to welcome you to Addis Ababa, the capital and the largest city of Ethiopia, but also which happens to be the seat of the Africa CDC here in Africa Union Secretariat. And of course, Addis Ababa is often referred to as the gateway to Africa. We are delighted to host the seventh Eliminate Yellow Fever Epidemic Strategy Annual Partners Meeting. Again, we'll take this opportunity to congratulate Ethiopia for hosting this year's meeting. Dr. Rosemary Dlamini, who is the country representative of WHO, would have loved to be here with us today, but unfortunately she had to attend to a very urgent official duty out of the country. So she did ask me to step in for her, and I'll read the speech on her behalf as follows. I would like, first and foremost, to thank the government of Ethiopia for presenting the chance to host this important meeting after the country's significant decision to introduce the yellow fever vaccine into the routine immunization program. Ethiopia's routine immunization program has expanded over the years to include 12 antigens in the schedule. This expansion has significantly contributed to the prevention of vaccine-preventable diseases. The country has continued to introduce new vaccines or switch the vaccines to expand its schedule. This includes expanding the human papillomavirus vaccine, which was previously only given to 14-year-old girls and will now be made available to girls from the ages of 9 to 14 years old. Rotavirus vaccine is switching to Rotacil. The addition of a second dose of polio vaccine, IPV2, and the introduction of malaria vaccine. Furthermore, efforts have been made to recover from the negative impact of the COVID-19 pandemic, the conflict, the drought. Campaigns were strategized and integrated to catch up on children who have been missed. The yellow fever campaign will be an additional opportunity to advance the priority agendas of the government of the Federal Republic of Ethiopia. Ethiopia has also been affected by yellow fever outbreaks in recent years, with outbreaks in 2013, 2018, and 2020. In this regard, I would also like to commend the efforts made by the government of Ethiopia to rapidly contain outbreaks, which was essential to ensure that the disease stopped before it spread into devastating epidemics. The recent subnational yellow fever risk assessment that has been conducted by the Ministry of Health in collaboration with partners and the Eye Strategy Risk and Analysis Working Group has revealed how great a risk yellow fever poses to all regions in Ethiopia. This assessment has also helped us to plan the preventive mass vaccination campaigns according to the determined risk level and has shaped our plan to implement the eye strategy in Ethiopia. Ethiopia is planning a large-scale yellow fever preventive mass vaccination campaign that will target over 95% of its population, equating to over 110 million children and adults. This huge task will be a great joint effort by the government and all eye partners. As of the 27 high-risk countries in Africa, we also need to strengthen our diagnostic capacity to confirm yellow fever and enhance the preparedness for the outbreak response. This means enhancing and extending the existing laboratory capacity. Currently, some of our neighbors, including South Sudan, Somalia, have experienced multiple outbreaks of vaccine-preventable diseases such as polio, leaving Ethiopia at risk of importation. Many countries are also struggling to manage the persistent yellow fever risk. This calls on us all to be deliberate in developing long-term solutions that ensure every eligible individual is reached and receives life-saving vaccines. To this end, I hope this meeting will bring us closer to the elimination of yellow fever epidemics. I would like to remind you to keep the meeting life balance principle. By this, I mean, in your leisure time, please take some time to visit the beautiful parks and museums located within a kilometer radius of this hotel. Together, in the lifetime, we can eliminate yellow fever epidemics in Ethiopia. So thank you so much and wish you great deliberations and looking forward to resolutions that will come out of this gathering and the roadmaps that will really help us to collaboratively work with every single partner, both at national and subnational level, but also with the developmental partners within the regions. As we all know, it's only through collaborative partnership that we can achieve more. And to this end, it is really very critical and important that we really work together with the governments with whom we are supporting. Advocacy for domestic resource mobilization is critical for us to implement this eye strategy. Supporting government in putting in place a resilient health system is also very strong. We know most of the countries in our region are affected by multiple health emergencies, including epidemics, either due as well as to conflicts, disasters, and these have often interrupted health system capacities, both at national and subnational levels. So as we gather here and we discuss strategies on how to implement the eye strategy, I think it's also very crucial, with the exception of advocating for governments actually to commit some predictable financing to this cause. It would also be crucial that we try to tap into the private sector in ensuring that we're able to mobilize resources domestically that will help us to build the capacities of the health systems, but also in the community. Primary health care is the way to go if we really need to sustain. We really need to work with the communities at large if we really need to move a way forward. Community engagement is very key in this struggle. So let's work together as a community, both in normal times, both in conflict, just to ensure that we have a robust health system that actually can withstand the impacts of health emergencies, but as well as both short and long-term disruptions. So again, we're looking forward to continue working with you. We appreciate your contributions and also the support that we'll continue to get from both the global and regional partners. So with that, I'd really like to thank you all and wish you a great deliberation. And I once again congratulate Ethiopia for hosting this year's meeting. Thank you very much.
Thank you, Dr. Alak. I'd ask you to introduce your colleague now from the Ministry of Health.
Okay, thanks so much again, Erin. And colleagues, as we said, that we as global partners are here basically to support member states to implement most of the strategies that we deliberate on, that we jointly work on as well. And it's very prudent to acknowledge if the roadmaps, the strategies, the policies that we put in place have to be implemented, certainly no other than the governments or the member states take the primary responsibilities for the implementation. Therefore, governments are our key partners as we march towards introducing the yellow fever vaccine in Ethiopia. We have again to stand up and see how best we work collectively to support governments to lead. We as partners, WHO and all other high strategy partners, our role basically is to support government to lead, to coordinate, to implement, but also to ensure that there's accountability, both at national and subnational level. So with these few remarks, we really want to applaud the government of Ethiopia who embraced this new strategy. And we're really very grateful that today we have a representation from the government of Ethiopia by none other than Mr. Lelisa Manuel, who is the senior advisor in the Minister of State's office, who will be making a key remarks on behalf of the government. So, Mr. Lelisa, most welcome, and you have the floor.
Thank you very much. So, for those of you who are here in person, welcome to Ethiopia. And today's meeting supposed to be opened by Dr. Dereje, but His Excellency is assigned for urgent work and is out of Addis. I am opening in representing him. Excellencies, Dr. Patrick Abok, WHO representative, Excellency Lawrence, High Strategy from WHO, Excellency Dr. Ephraim Levango, my former boss and my friend. Now he's changing his jersey to UNICEF. So all participants, distinguished guests, ladies and gentlemen, welcome to Ethiopia, land of origin, land of mankind, and welcome to the beautiful city of Addis, the political capital of Africa and seat of the African Union. Everyone, welcome home. Ethiopia is a land of origin and it's home for every one of you. So I welcome you. It is a great pleasure for Ethiopia to host the 7th Eliminate Yellow Fever Epidemic Strategy annual meeting here in Addis. I am delighted to be part of this high-level event and honored to address the opening keynote on behalf of the Minister of Health and myself. As we all know, yellow fever is a mosquito-borne disease caused by yellow fever virus, resulting in acute hemorrhagic fever with a very high case fatality rate, which is up to 50%. It is transmitted to humans from non-human primates and vice versa through vector mosquitoes. There is no specific treatment for yellow fever apart from symptomatic supportive care to reduce the disease. And yet vaccination is the single most important intervention to prevent this yellow fever. The World Health Organization estimates that annually, the World Health Organization estimates that annually there are 2.2 million new cases and 30,000 deaths, with the majority occurring in sub-Saharan countries, in sub-Saharan Africa. So 27 countries in sub-Saharan, including Ethiopia, remains at risk of yellow fever infection. Yellow fever cases have been increasing since the early 2000s due to a factor such as low population immunity, deforestation, urbanization, population movement, pandemics like COVID-19, climate change, and environmental change. To address this, the Global Yellow Fever Initiative was launched in 2006. Currently, the world is implementing the Eliminate Yellow Fever Epidemics strategy, a collaborative initiative between WHO and UNICEF, supported by Gavi Alliance and other partners, targeting 40 high-risk countries, of which 27 are in Africa and 13 are in Central and South America. The African region launched in 2018 with the objective of eliminating yellow fever epidemics by 2026. The yellow fever vaccination is highly effective and safe, providing protection of 90%, 95% of vaccinated individuals for life. Ethiopia has experienced yellow fever epidemics with outbreaks reported between 1950 and 2020. Particularly in the southwest part of the country, the first confirmed cases in Ethiopia was reported in 1959 in the Wallagga province, Oromia regional state. Between the first case and the 2020 outbreak, Ethiopia reported over 117,000 cases and 30,595 deaths with a case fatality rate of 26%. In response to outbreaks, Ethiopia conducted reactive mass vaccination campaigns. Distinguished guests, ladies and gentlemen, given the high risk, Ethiopia has been implementing recommended strategies to eliminate yellow fever epidemics, including strengthening surveillance, conducting reactive campaigns, ensuring travelers' vaccination, and integrating preventive strategy into routine primary health services. Ethiopia included the yellow fever vaccine introduction plan in the National Comprehensive Multi-Year Plan 2016 to 2020. Additionally, Ethiopia developed a 3-year eliminating yellow fever strategy implementation plan 2028 to 2021, 2018 to 2021 with multi-thematic interventions. In 2018, the National Immunization Technical Advisory Group recommended the introduction of the yellow fever vaccine in both the routine immunization and phased preventive mass vaccination campaign. However, further evidence on regional risk levels was recommended by the Interagency Coordination Committee before implementation. Subsequently, a yellow fever subnational risk assessment was conducted, showing varying levels of risks across all regions, with the SNBR, Oromia, and Sidama regions at the highest risk. To generate more evidences on the best strategy for introducing the yellow fever vaccine, the Ministry of Health's Research Advisory Group conducted a scoping review and recommended national introduction of the yellow fever vaccine into the routine immunization and a risk-based phased immunization. Following the recent ICC endorsement in January 2024, Ethiopia plans to introduce the yellow fever vaccine into the routine immunization and conduct multi-phased approach to be completed by 2025 to 2029. The objective of this is to halt yellow fever transmission and to eliminate yellow fever epidemics by achieving vaccination coverage above 95%. The routine immunization programs aims to vaccinate over 3.7 million surviving infants annually, and phased vaccine aims to vaccinate over 110 million people aged 9 months to 59 years in 5 years. This initiative will also strengthen routine immunization, acceptance, and uptake, as well as yellow fever surveillance. Distinguished guests, ladies and gentlemen, the Ministry of Health Ethiopia has endorsed the introduction of yellow fever vaccine, considering the commitment of the Ethiopian government and the potential support of the partnership with donors and implementing partners. Despite facing several challenges, Ethiopia is committed to this endeavor and calls on all partners for continued support to realize this ambitious plan. In conclusion, preventing yellow fever is crucial for achieving universal health coverage and creating a healthy and prosperous world. I officially declare this high-level event open and wish you every success in your deliberation over the next 3 days. I am confident that the outcome of this meeting will greatly benefit global and regional efforts toward eliminating yellow fever epidemics beyond the life of the eye strategy. Thank you and enjoy Addis.
I'd like to thank both Dr. Abba and Abak and Dr. Manuel for their words about the commitments that Ethiopia has to improve primary health care, including vaccine delivery and vaccine coverage, particularly for yellow fever and why we're here today. I experienced some of that as the chair of the yellow fever vaccine risk analysis working group with the Ministry of Health representatives who were present at every meeting, adding important contributions, collecting data, and providing key information during weekly discussions to shape and really dictate what the risk is for Ethiopia. And finally, I want to think that the words of the need to work together as a global health community. That's why we're all here today. You know, it is key that we work together because the only way that we're going to eliminate yellow fever epidemics is working together as public health agencies and groups to be able to combat that. With that said, I'd like to thank again our distinguished guests. We're going to have a group photo with our distinguished guests, and then we'll come back and we'll start our discussions again. Thank you. Can I ask everyone to please retake their seats, please? Unless you don't want time for coffee later. Okay? Because that's what's up in the air if you don't pay attention. All right. So thank you everyone for the photo. I have the pleasure of introducing our next speaker, Dr. Ephraim Lamango. He is the Associate Director in charge of immunizations at UNICEF, and he'll be providing some opening remarks.
Hi, good afternoon. Can you hear me okay? I want to make sure my voice wakes you up if you're planning to speak. Ladies and gentlemen, excellencies, colleagues, friends, and former colleagues. It's a great pleasure for me to be here in Addis today and a pleasure to join you here in person. Joining some of the other colleagues, I'm going to welcome you to my hometown, Addis Ababa. I do hope you get a time to go around the city. But first of all, I wish to start my note by congratulating our host, the government of Ethiopia, on their momentous decision to introduce yellow fever vaccine for routine immunization. This has been a long overdue, but it's great to see that now it is happening. And this leaves us as global partners of the eliminating yellow fever epidemics, with only, I think, South Sudan and half of Kenya to go. And also great to see that there will be upcoming preventive mass vaccination campaign in a phased manner. I would like to appreciate as well the leadership of the Ministry of Health and its commitment to reach unvaccinated children, and notably your commitment to conduct the big catch-up that we expect you will be able to fill in significant immunity gap in children that were missed during the pandemic. UNICEF, along with the other partners in this room, is proud to contribute to the ongoing efforts to make yellow fever vaccine part of the routine system in Ethiopia. And I once again reiterate UNICEF's commitment to stand shoulder to shoulder with you in the road ahead. In my address to this meeting last year, as some of you may remember, I did my address virtually. And I recognize this partnership as perhaps one of the most impactful and the strongest partnerships in the immunization space. I repeat that today. It is one of the strongest partnerships we have in the immunization space. But our success heavily depends on how we have been able to collaborate since 2017 to reduce the catastrophic risk of yellow fever. One notable achievement is our joint effort to expand access to yellow fever diagnostics through contribution of partners such as FIND, Gavi, the US CDC, WHO, and many other colleagues in this room. This has enabled UNICEF to work with manufacturers and many other partners to bring affordable and quality assured test kits to the market. And we have delivered so far over 80,000 ELISA and PCR test kits to 21 countries in the effort to diagnose yellow fever as quickly as possible. This has helped to reduce the time needed to confirm a new yellow fever outbreak and expansion of an existing one by about 70%. This is a remarkable progress in our effort as partners. Through the efforts of this partnership, until last year, over 260 million people in Africa have been protected through vaccination campaigns. This is a figure that has doubled over the past 5 years. Despite our efforts and commendable progress as partners, we still have several challenges remaining, and I wish to mention 4 of them. And I believe this discussion will be able to at least deliberate on these important topics. One is the timeliness of response to outbreaks. At times, we have seen yellow fever outbreaks have taken months to be notified, with subsequent delays in implementing reactive vaccination campaigns. Lack of integrated campaigns have been draining governments due to the repeated series of single antigen campaigns, and this may have led some countries to have campaign fatigue. The growing number of conflicts across several countries in the African continent, and of course the climate-related fragility that we are seeing across countries, is going to continue to thwart our efforts and achievements. The resurgence of yellow fever in Western African countries is something that actually requires our immediate attention to resolve. These are the key challenges that actually require our utmost attention, our most impactful partnership, and above all, countries' political commitment to be able to take this forward. But there are hopes and trailblazers that could be quoted as promising practices. The recent yellow fever outbreak response in South Sudan, I think, sets the mark that is able to meet all the KPIs needed in responding to such outbreaks timely. The integrated campaign, the yellow fever and measles-containing vaccine campaign in Chad, is something to also mention. But globally, there is also an ongoing effort by the Immunization Agenda 2030 partners to look into the key challenge of responding to outbreaks quickly. And this is hoped that it will be able to lead to key recommendations to resolve some of the global level bottlenecks that sometimes thwart countries from responding to outbreaks quickly. I wish to mention the opportunities that the big catch-up that is currently availing in Ethiopia and beyond. We are expecting over 20 countries to apply for funding to Gavi to conduct the big catch-up, which is a catch-up activity that allows countries to conduct multi-antigen series of campaigns through fully funded vaccines. And this is for the vaccines that you already have in your routine immunization systems. And we hope this is once in a long time opportunity that is able to support countries to fill in their immunity gap. And those countries who do have yellow fever vaccination in their routine system, they are eligible to apply for yellow fever vaccines to vaccinate children that were missed during the pandemic. Even though the number of zero-stress children is beginning to come, is already beginning to come down with the big catch-up and many other recovery efforts, there is more work to be done if we are to face this important challenge. Over the next 3 days, we have a chance to ensure we consider factors that will be able to help us go forward with our success of eliminating yellow fever as epidemic. Notably, your discussions on vaccine supply, community engagement, surveillance, partnerships, and political commitment will be instrumental in coming up with a clear declaration or sense of commitment to this. The target date of achieving the eliminating yellow fever epidemic goals by 2026 is now less than 2 years away. And as most of us know, time flies. And 2 years is just now. But failure is not an option, even though it looks like a very challenging task. Failure cannot be an option. We need to do all our best to be able to get there. So as we look ahead to 2026, on behalf of the partners, and of course UNICEF, will continue to stand in partnership with countries as we strive to protect every child and their families from yellow fever for good. Thank you very much and have a wonderful deliberation.
Thank you very much. I know that our distinguished guests have other meetings to go to, so if you would like to leave, please feel free to do so before I turn it over to Laurent. Laurence does not need much of an introduction, as almost everybody in this room knows her quite well. But Laurence Leroux is of course, focal point for yellow fever at the WHO headquarters, and has a team that has been supporting and really seeing the life of the eye strategy. So I am quite delighted to turn the floor over to Laurence to give an update on the global eye strategy.
Thank you very much, Erin, for this introduction. Good afternoon to everyone, and good afternoon to you, Ephraim, as well, and representative of the I leadership group. Thank you so much for your kind words and your commitment thus far. Dear representatives from the regions and the countries, dear colleagues, and the Toiletru, again, it's my pleasure to welcome you all to the 7th annual partners meeting. It really is a great honor to be hosted by Ethiopia shortly after the critical decisions to introduce the yellow fever vaccine into the routine immunization scheduled. So I'll be providing a global update of the eye strategy, really speaking as Secretariat on behalf of the partnership. Next slide, please. So together and throughout the meeting, we're going to discuss the progresses around the 3 strategic objectives of the eye strategy: protecting at-risk populations, that the vaccination component, preventing international spreads, we're talking about protecting high-risk workers, applying the international health regulations, but also all the work on urban resilience and urban risk management. And then last but not least, the pillars on containing outbreaks rapidly, where we talk about surveillance, laboratory capacity for early detection and confirmation of yellow fever outbreaks, as well as response. So I also want to insist on the competencies for success that we see only partly on the slide. If you could move away from the photo of the meeting room, that would be helpful. But actually, this competency for success really talk about strong political commitment, high-level governance with long-term partnerships, the importance of having affordable vaccines and sustained vaccine market, the synergies with other health and non-health sectors, and research and development for better tools and practices. And these were developed also very much based on lessons learned from other programs. They were very true at the time of the development of the strategy. They remain core guiding principles for us, as you will see throughout the meeting and the 3 days. Next slide, please. So we'll hear detailed epidemiological updates from the regions and the countries, but I wanted to, for the newer friends of the strategy, I wanted to highlight that since eye inception, 4,106 cases of yellow fever have been confirmed in Africa and the Americas, with peaks of incidence in 2016 in the Africa and in 2017 and 18 in the Americas. Please note that the 2023 incidence data are not represented in the slide deck, as we continue to work on final case classification for the year that just ended. But I think if we contrast those figures with the numbers that hopefully some of you can see at the bottom of the slide, with the estimates of incidence and fatalities of up to 130 1,000 cases of severe yellow fever cases annually, with up to 80,000 deaths, most of them being in Africa. We have a clear indication that of the extent of underdiagnosis and notification. Since our inception as well, 48 outbreaks have been detected, with an overall increase since 2020, and we understand why later. I want also to flag that over the last 2 years, there's been a reduced number of large or disruptive outbreak, and this is in part linked to the immunity context in which this outbreak occurred. Next slide, please. I'd like to also highlight that the scope and the scale of the efforts that we're doing is really driven by the high impact nature of yellow fever, as well as its climate and environmental sensibility, as was discussed earlier. But it's really, be it through the changes in vector densities and distribution, climate stress, and the impact on migrations, population movement, change in land use, in habitat. And again, for the newer friends of the eye strategy, I'd like to reflect how the high impact nature of the disease is exemplified through two critical yellow fever crises. The first one being in 2016 in Angola and DRC, with two linked urban outbreaks with 663 confirmed cases and 137 deaths, with over 7,000 suspected cases. Two capital cities were affected with an outbreak that was widespread in Angola, and importantly, this occurred after a 28-year hiatus since the last outbreak. The response to this outbreak exhausted the global yellow fever vaccine stockpile, with over 130 million people that needed to be vaccinated to contain the outbreaks. And there was also a concern about potential spread to other regions, as 11 cases were exported to China. And importantly, again, talking about the high impact of the yellow fever outbreaks, there were extended disruptions of the preventive programs, both in the affected countries and beyond, and that lasted for about a couple of years. This event is what triggered the creation of the eye strategy, and the definitions of our objectives and competencies for success. The second example I'd like to walk you through is still on the same slide, the 2017 and 2018 outbreaks that affected the coastal areas of Brazil, and with active yellow fever circulations at the doorstep of large and densely populated urban centers in Rio de Janeiro, Sao Paulo, and Bahia. This was the largest outbreaks of yellow fever detected in the Americas in over 50 years, and it happened in areas that have been unaffected for yellow fever by over a century. And there were more than 2,000 cases confirmed and 745 deaths, with here again large-scale reactive vaccination efforts to contain the outbreak and preempt the outbreak, with over 21 million people vaccinated in those 3 states. So on the next slide, we'll now discuss the eye progresses using the example of Africa, as well as some of the emerging challenges and opportunities to address and adjust. So as was mentioned by Dr. Ephraim, there have been 264 million people protected against yellow fever for life via campaigns in Africa since our inception. Angola, Ghana, Sudan, and Congo have achieved nationwide protections via campaigns. Nigeria, DRC, and Uganda have continued or launched multi-year campaigns in 2023 and will continue in 2024. Chad launched a multi-year campaigns in 2024, very recently. Niger will launch as well, and Guinea-Bissau has applied for preventive campaigns. In terms of routine immunization, Uganda and South Sudan have introduced yellow fever vaccines into the routine immunization schedule, leaving, as was mentioned, only Ethiopia and South Sudan to yet introduce, with with also discussions with Kenya to scale up the routine immunization delivery to nationwide scale. There were also catch-up interventions, namely in Sudan, to close immunity gaps linked to a delayed introduction of the yellow fever routine vaccine into routine immunizations. And another important number here, that there's also an estimated 120 million children who have been protected by routine immunizations. Now, these figures are based on the number of doses that were targeted using estimates based on the usual wastage rates for routine. I also want to again applaud the decision of Ethiopia to decide to introduce into routine and counter preventive mass campaigns. We also have discussions with Equatorial Guinea for a campaign next year. So I think it's important to note here that if you look carefully at the map, to note that the preventive mass vaccination campaigns and routine immunization efforts have focused in the countries that did not benefit from preventive mass vaccination campaigns before. And these are represented by the varied shades of purples and somehow pink in the slide, except for the darker ones, which are the countries which benefited from campaigns under the Yellow Fever Initiative. Next slide, please. So the rollout of these campaigns on such a large scale has been driven by the core principles of the synergies and integrations. For instance, the yellow fever campaigns have been used to catch up measles zero-dose children that happened in DRC. There was also integration with measles and meningitis that was done in Nigeria, that was also done in Guinea in terms of for the outbreak response. Also, the principles of equity, where we're trying to identify and protect seasonal workers, ethnic minorities. This has been achieved, including in outbreak response context, as well as the protection of refugees and host communities, as was done in Sudan, as was done in Nigeria for Borno State, and as was mentioned by Dr. Ephraim, was also done recently in Chad in integration with measles, where refugees from Sudan were protected. And importantly, we're working in alignment with the IA 2030. The key principles, again, of the I strategy are also the fact that it's delivered through regional frameworks, and we hear from our regional colleagues later on. There's been a resolution at the regional Afro committee. There's also an endorsement of the strategy at the TAG PARO meetings. And importantly, this rollout of campaigns has been materialized, has been made possible by the country's leadership, as well as partners' coordination and support. And it's been made possible by the increased yellow fever vaccine supply. We're far away from the situation we were in 2016. The global yellow fever vaccine supply has more than doubled since the I inception. And for instance, more than 62 million doses of yellow fever vaccines have been allocated for preventive mass vaccination campaigns in Africa for the year 2024, in Nigeria, DRC, Uganda, Chad, and in Chad that will enable a nationwide completion of the campaigns, as well as in Niger. And I want here to highlight and appreciate the work of the I Demand and Supply Working Group, which is working on demand forecasting, supply procurement, and market shaping. And this is with the insight and expertise and support of UNICEF, Gavi, and the PAHO Revolving Fund. Next slide, please. So really core to the I strategy is also the importance of making risk-informed decisions, risk-informed interventions, and risk-informed prioritizations, with continued efforts to increase the accuracy and timeliness of yellow fever data reporting. We're holding surveillance workshops, trainings, developing guidance materials, including for case classifications. There have been strong efforts, you hear later on, in terms of building the laboratory capacity via the Laboratory Technical Working Group, including through the procurement of bundled diagnostics tools via UNICEF, which is a very innovative approach that is being explored for other diseases. And also want to highlight the great efforts made in terms of contracting the time for yellow fever confirmation at regional level, both through the capacity building, regional capacity building, as we now have 3 regional reference laboratories for yellow fever, but also through faster international samples transport through the IOPS mechanism. So obviously, there are challenges with yellow fever diagnostics, be it clinical, epidemiological, laboratory. And again, we will hear more details about this throughout the meeting. But I'd like also very much to address the country here and highlight how better quality data can lead to better outbreak identification and management of acute events, but also to better inform decision, resource allocations, and support. And a key example of here is the work done through the risk analysis working group, which is chaired by Erin, and working both on national risk analysis and risk ranking to inform the vaccine allocation process, but also guide preparedness and identify countries where immunity gaps should be closed as a priority, either through routine immunization or, as we'll see, targeted catch-up interventions. And the risk group, importantly, is also working at some national risk level to phase the different increments of the preventive campaigns, as is recently done in Ethiopia. And I think importantly, in terms of, again, informing decisions and prioritization, I would like to flag as well that the risk group will also be looking at other elements of risk and risk in lower areas. But I think the key here is that we're really striving to be as close as possible from the needs and the realities at the country level. And I would like to really think that this is a key features of this partnership and our efforts. Next slide, please. So as large-scale preventive mass vaccination campaigns are being rolled out in countries without recent history of outbreaks, yellow fever outbreaks have emerged in the last 2020, predominantly in countries with history of campaigns under the Yellow Fever Initiative, which lasts from 2005 to 2014. And these are the countries that are outlined in a bold dark on the map on the left. But really, these are different geographies compared to the one where we are rolling the campaigns. So there'll be a dedicated presentation on this, but briefly as an introduction to set the stage for the discussions, I want to highlight that since 2020, there's been 15 countries reporting confirmed and probable cases with 29 outbreaks and situations with epidemic potentials, of which 11 were disruptive. The resurgence is predominantly affecting countries with history of campaigns, I've mentioned, but it's also affecting areas where yellow fever had not been seen in the first place or where campaigns are yet to be implemented. And this is represented fairly clearly on the graph, which is on the right side, where in red you see the outbreaks occurring in countries with history of preventive campaigns. With the resurgence in 2020, in this graph, you also see that in the absence of large-scale interventions and prevention, the yellow fever risk of outbreaks persists. These are represented by the orange bars. And you see through the blue bars that, and it's mostly the case of Nigeria, where campaigns are rolled out, they are efficient to control the yellow fever risks. Next slide, please. So the outbreaks were very resource intensive to control, with more than 14 million doses awarded through the ICG for outbreak response. They were also marked by key features, the fact that they were affecting nomadic, vulnerable, and hard-to-reach communities, the fact that they were also involving high-risk seasonal workers. They were also linked to suboptimal routine immunization coverages, and marked by an important urban threat and risk of international spread. There was also, as was flagged, real and marked challenges and delays in terms of outbreak notification, investigation, decision-making, and implementation. And we'll look again into more details throughout the meeting, but I want to highlight here some of the key actions taken to address this characteristics of the outbreak. So for instance, we're working with the humanitarian communities to understand how we can reach the nomadic and vulnerable communities and provide bundle services. For the high-risk seasonal workers, we're starting to engage with the private sector, and we have concrete examples of this being done in Central African Republic for outbreak response. We are working with the eye vaccine delivery working group, but also RITAG and SAGE to characterize and address these immunity gaps linked to suboptimal routine immunizations. In terms of mitigating urban risk, that's where we're collaborating with the preparedness and the vector communities. And there'll be also efforts by the high-risk analysis working group to identify higher risk urban centers and risk in those lower risk areas. And in terms of the major challenge around the outbreak response delays, I think we're working also towards awareness and capacity building. Here again, developing guidelines and tools such as the risk communication and community engagement readiness toolkit for yellow fever. There are tools being developed for root cause analysis and to understand the delays for outbreak response. They will be discussed in details later on. And we're also working with the ICG and the IA 2030. This is a specific initiative working group and outbreaks task team as we continue to build surveillance and laboratory community. But the common thread here among all these interventions is that they're targeted and nuanced approach. And again, we're trying to be as close as possible from the realities and oriented toward collaboration and synergies, with the eye secretariat providing coordination across the disciplines, the levels and the regions. I want to flag here that we do have limited clinical information and description of the yellow fever cases. We're working to make sure that this changes, but also we have limited insight on the clinical management of the cases, especially in the African regions. And here I want to highlight the ongoing collaboration with the Global Ababa initiatives on the development of clinical management guidelines for yellow fever. Next slide, please. So in summary, and again, with thanks to Dr. Ephraim for the kind introductory words, the eye partnership is really shaping the global yellow fever landscape as a community, working toward achieving our milestones. We've made critical advances in the rollout of the large-scale preventive mass vaccination campaigns, with emphasis on risk-informed prioritization and decision-making. New challenges have indeed emerged, but we've been able to identify them, and we're working toward addressing them, which I think is a very critical point. And this includes the resurgence of outbreaks in countries with history of preventive campaigns. And we'll talk about these new targeted approaches for catch-up interventions and closing empty gaps, but then also the threat of urban outbreaks with the risk of international exportation and spread. Some critical challenges remain, and some are non-unique to yellow fever. This includes, as was flagged by His Excellency from the Ministry of Health, challenges with prioritization of yellow fever and competing priorities. And the issues of prioritizations are actually true across multiple levels. And I think this is really making the efforts to integrate and leverage the existing mechanisms to advance the yellow fever agenda all the more critical. And this is also speaking directly to the capacity at country level and the importance to provide direct support and technical assistance. Underdiagnosis is also an issue, with at least in Africa an emphasis on the laboratory results for the case confirmation. And I think this is a potential areas of collaboration between the regions, and I hope we'll be able to discuss during those 3 days. And the vision for us is really to be able to respond to the country's needs and the demands. Hence, again, the importance of concerted and optimized approach among partners, with the countries leading the charge on yellow fever and the partnership and support. And in the spirit of the partnership and optimizing resources, I do hope that we can advance the cross-regional collaboration, especially as now in-person direct collaboration has resumed after the pandemic. So we'll advance on the next slide. We'll advance on this agendas as guided by the midterm evaluation of the I strategy, which provided 8 key recommendations that should show in the next slide, but they entail ensuring sufficient capacity, working in synergies and partnership. It entails as well a renewed commitment to the I strategy, an increased awareness. I do not know all of them by heart. It would be easier if I could have the slide. Meetings of the partnership, the meeting and process is really very much.
And Addis.
Next, please. Okay, so a risk analysis was conducted, which brought 27 risk countries in Africa. These are the criteria were used to classify these countries. So we have 100 countries. There's underlying risk of yellow fever virus circulation in the area. The disease or epidemic risk with risk of rapid amplification, and then the mitigation factors where we have vaccination coverage in population. So these are the criteria we used to bring out the 27 high-risk countries in the region. Next. So this is just to show the ranking. So we have 5 countries that have been ranked as the highest risk countries for yellow fever: Nigeria, Cameroon, Democratic Republic of Congo, Ghana, Uganda, and then 6 other countries that have shifted up their ranking compared to what they were before in June 2022. So like South Sudan has moved up by 4 positions, and then Benin, Ethiopia, and Togo by 3 positions, Cameroon and Liberia by 2 positions. Next. And this ranking was done last year in June. Okay. So the vaccination approach to maintain high population level in high-risk countries is reflected here with these 3 preventive mass vaccination campaign, catch-up campaigns, and then the inclusion of yellow fever vaccine into the routine immunization schedule. Next. So this slide from the presentation, well, you can see the figure is a bit different. We are talking of 377 million people protected because we added the children vaccinated through routine immunization to those that were vaccinated during campaigns. Let's move on next. So I think there's also a mention of the yellow fever vaccine allocation for preventive vaccination campaign in 2024. So you can see countries that plan for campaigns 2024, and then for Ethiopia in 2024-2025, the entire country in different years. Next. Put vaccine into the routine program. So we are at 25 countries out of the 27 countries. So it's only 2 countries, Ethiopia and Sudan, that are yet to introduce the yellow fever vaccine into their routine program. We introduced only in 4 counties, and you can take note of the observation there. In 2022, we had an outbreak in 3 counties that were not previously considered as non-high-risk areas. Comparing the unique coverage for yellow fever and measles-containing vaccine first dose. This is for the 2022 one-week report. Just to show that if you look at it over the years, we are seeing gaps, but at least the gaps between the 2 vaccines that are given at the same time have been reduced drastically over the years. We still have some countries like Angola, where the gap is still there. Kenya the difference just because the county is only 4 counties that are implementing yellow fever vaccine in routine. And then from the last date on the right hand side is because we introduced the vaccine in October 2022. So it was like just 2 months of implementation, and then the difference with the measles vaccine could be well understood. Next. Moving to the second objective, I think we have 2 slides there. Move on. So, we have a big capacity of Addis countries on surveillance, especially at the point of entry, with emphasis on cross-border collaboration for surveillance in countries, and the screening and control of yellow fever vaccination cards is basically done in most of the countries in the region. And we have also raised awareness among travelers about the yellow fever vaccination. I think most of the countries are doing that. Next. Okay, so this map is showing the country requiring proof of yellow fever vaccination for travelers as a condition for entry. I think for the Afro region, it's basically only Lesotho where that requirement is not done at the point of entry, but basically most countries do that, and it's a good practice for the AI strategy. Next. Objective 3, move on. So I think, okay, this is the epidemiology of yellow fever in the region in 2022. So we had, as said before, a resurgence of outbreaks, and we have 14 countries that reported confirmed cases in 2022, and these are the countries that are shown on the left-hand the map on the left-hand side. We had 5 countries out of these 14 that conducted a reactive campaign. And then in 2023, 8 countries reported confirmed yellow fever cases, and 3 countries conducted a reactive campaign, which are, I think, Chad, Cameroon, and then Guinea. Yeah, Guinea. Next. Okay, this is surveillance performance indicators from January to December 2023 by country. Where you have green, we are doing well, but where we have what is called this color? Purple. We are not doing very well. We should have put it red, in fact. So in terms of cases reported within 7 days of onset, I think most of the countries are doing well. Where you don't have data, we are struggling to get data from these countries. Even Ethiopia, where we are, we can see that we are not receiving data, basically to have these indicators. So percentage of specimens received in lab within the 3 days of being taken is one of the challenges, especially getting samples from the operational level to the national level. Even though with IOPS we have this facility to take samples from the national level to the regional reference lab, but taking the sample from the operational level to the national level always brings challenges. Then I think we are also, the last column is the percentage of districts that have met the 2 indicators is also low. Next. So talking about the reference, regional reference lab, as you saw in our milestones, we had only one single lab in the region, reference lab, which is Institut Pasteur in Dakar. That was in before 2017, but efforts have been made. So we are now having 3 regional reference labs. The Institut Pasteur Dakar, Institut Pasteur in Dakar, Senegal. We have the Centre Pasteur Yaoundé in Cameroon, and then the Uganda Virus Research Institute in Kampala. Next. So some examples, I think, Lawrence made mention of this. So Kenya is one of the places where we had yellow fever outbreak in previously unaffected area, and we had 3 confirmed cases and 11 probable cases, and the 2 counties were affected. So the country managed to react to that outbreak with support from partners. Next. That was in 2022, and then the South Sudan is an example of yellow fever outbreak in previously affected area, and we had 2 confirmed cases and 1 probable case, and there was also a reactive campaign that was last year in 2023, with some good results that were achieved. Next. So this in terms of the continued intensification of yellow fever transmission in Africa after the peak that we had in 2022, in 2020, sorry, with the number of outbreaks, if we look at it from 2017 to 2023, though it has decreased from 2022 to 2022, but we are still having concerns, especially on the risk in urban centers, and the number of countries that reported confirmed and probable cases actually increased from 11 in 2021 to 14 in 2022. Next. So this has been mentioned, the challenge that we have in having a timely response to yellow fever outbreaks. You have some examples there between the onset of the outbreak and the time the response is provided to the outbreaks. So looking at the whole chain from onset to notification to the request to ICG, the decision of ICG when the vaccines are shipped to the country, and then when the campaign starts. As you can see, for example, notification is taking up to like 52 days, 62 days, for example, in one of the countries. The time between notification and ICG request, sometimes up to 64 days. The time between the ICG request and the ICG decision, that's where we are doing well. And thanks to ICG, is basically less than 10 days, the decision is made. And then the vaccines are shipped to countries. But if you look at the time between the ICG decision and the time the campaign will start, that's the purple section of the graph there. You see that sometimes countries go up to 100 days before the campaign can start. And then the duration of the campaign sometimes goes up to 54 days because of maybe so many other challenges. Next. So we put a slide here on the level of implementation of the midterm, the midterm evaluation. on the recommendation that Lawrence made mention of. So there are a few of them that were actually for which the region was to take actions. The first one, address critical capacity requirements for effective implementation of the I strategy by reviewing resources available. So we have some actions that we planned, and some of them basically are on track. There was another one on improving integration and synergies for maximum impact by ensuring high representation in Immunization Agenda 2030 structures. This one is also in progress, and one of the actions was to support countries while developing their national immunization strategy to make sure that yellow fever surveillance and outbreak response is included as and addressed in the strategy. So most of the countries either have completed the development of their national immunization strategy, or some are still doing that, and we are making sure that the I strategy is well placed in those plans. The recommendation number 7 was to revise the I monitoring and evaluation framework and monitoring approach. This has been done. We reviewed and updated the region-specific indicators for the I implementation. And then the last recommendation was to develop a 3-year I transition and sustainability framework for the period 2024 to 2026. We have prepared an operational plan, which is ongoing, and then the framework that I talked about, which is also ongoing, and a progress report will be submitted to the regional committee in August. Next. Next slide, please. So we have a list of challenges. Of course, the COVID-19 pandemic did not help us in terms of surveillance, in terms of political commitment, and even in terms of vaccination coverage and the surveillance. The decision making of some countries for the routine immunization in production, I think we have Ethiopia that has done that, so we are remaining with just one country to do that. The low routine immunization coverage is leading chance of epidemics in countries that have already carried out preventive mass vaccination campaigns. We have already talked about the challenges in domestic samples transport from the field to the national level. We have security and uncontrolled population movement in countries that are facing humanitarian crisis or security crisis. No yellow fever protection policy for vulnerable population exposed to the risk of salvific transmission. I've talked about mining companies, workers, migrants, and all the rest. And then I think we are also facing the funding gap in Africa, especially to get more resources to support the I strategy. Next. So some lessons learned and key approaches for I implementation. I think the successful implementation of the regional operational plan will depend on regional and member state engagement and political willingness to eliminate yellow fever epidemics. And it's also aligned and effective partner support, including from the private sector, civil society, brought together, will assist in the success of the strategy. We are glad that we have a very good collaboration and synergy with the partners, and the integrated disease surveillance and response IDSR as well as the PPD surveillance system is also key in ensuring that we improve our surveillance, and then the integration that we have talked about with preventive mass vaccination campaigns for other diseases in most of the countries. Next. So some next steps for the implementation of the recommendations of the I strategy midterm evaluation. So we are working on those recommendations as shown previously. We're also supporting Ethiopia now for the Gavi application that they are going to submit to Gavi. Planning and implementing activity to protect high-risk workers and vulnerable population, including the international health regulation, and then the root cause analysis and immunity gaps analysis of resurgence of epidemics in countries that have already conducted large-scale vaccination campaign, and also the support to countries that are going to organize catch-up campaigns. Next, of course, the big catch-up is also one of the priority in the region. So we are using that also as an opportunity to increase vaccination, the yellow fever vaccination coverage. So with this, I would like to thank you for listening, and thanks again to colleagues that have put together these slides, and thank you.
Thank you so much, Maury and Adu, for putting that together. We'll hold questions until after our last set of presenters, but I want to send some apologies. We were having technical difficulties. People online lost audio, and that's why there was so much activity and some pop-ups. So hopefully we now have it resolved. It's gonna go swimmingly, guys. All right. So my pleasure to introduce colleagues from the Pan American Health Organization, specifically Mark Lundy and also Alvaro Wittenberry, who will be providing a regional update for the Americas in regards to yellow fever. Over to you.
Thank you, Erin, and thank you, colleagues from the I Secretariat. Thank you, Tom, as well, colleagues from Ethiopia, for welcoming this meeting in this beautiful country. I had the chance to spend a few days in the Omo River Valley before coming here, and it was amazing. So I'm very happy to be here. With Alvaro, we will present a regional update on the yellow fever situation in the Americas. The idea of this presentation is to try to also introduce a little bit the situation in the Americas, because most of you may not know the epidemiological challenge that we have there. So I will start talking a little bit about the situation, and then I will leave my colleague Alvaro speak about the immunization update, and then we will finish with some way forward for the region of the Americas. So in the Americas, since we have a plan B. Thank you, Alvaro. So in the past 60 years, in the region of the Americas, we've had nearly 9,400 cases of yellow fever that have been reported, including 3,300 deaths in 13 countries. This is about like 150 cases reported per year, but you can see that we've had years with like very important epidemic, and the last large epidemics were reported in Peru in the 90s, and more recently in Brazil in 2017-18. Next slide, please. If we look at the situation in the past 20 years, we can see that most cases were reported in Brazil, Peru, Colombia, Bolivia. And this is largely explained by the large outbreak we had in Brazil in 2017 and 18, where more than 2,000 cases were reported in 2 years. Next slide, please. Next. Sorry, I have some title slides. So I think something that is important to discuss a little bit about the situation of the yellow fever in the Americas is the transmission cycles that we have. So in the Americas, we haven't been able to show evidence of urban transmission cycles since 1954. So the transmission cycle that is being seen in the region is a selective transmission cycle, predominantly affecting non-human primates, so monkeys, basically in the jungle. Human cases are usually sporadic in rural areas, but in the past years, and especially in Brazil, during the 2017-18 outbreak, we saw cases in urban or peri-urban settings, and this has to do with the fact that related to deforestation and changes in the urbanization in many countries, the non-human primates are now living very close by the cities. So we now have a sylvatic transmission cycle that can actually occur in an urban context. We will talk much more about that in 2 days in a session specifically on this. With regard to the urban transmission risk, the risk persists because there is a high density of Aedes aegypti and low yellow fever vaccination coverage in many big urban centers. And furthermore, the global warming and deforestation has an impact on the distribution of urban vectors. So if we move to the next slide, we can see the distribution of human cases and epizootic, so cases in non-human primates. And what we can see is that usually we have some cases among non-human primates occurring shortly before the occurrence of cases among humans. And that's quite important because this will guide a little bit our surveillance strategies and surveillance recommendations now and in the roadmap that we're working on. You're trying to use basically the epizootics as a sentinel sort of surveillance for what will happen among the human cases. Next slide. The current response. Regional context. Yes, some important data which are specific to the region of the Americas, but also I think to the African region. Because of the climate change and the deforestation, we have a shift in the distribution of vectors, but also a new phase of the interface between human and wildlife habitats. So you can see on the right-hand side a photo of an urban center where you can basically see that the jungle is actually getting really it's more at the rivers. The city is actually coming into the jungle. So now we really have this wildlife habitats and urban centers living together, thus having a great impact on the risk of peri-urban transmission using with a sylvatic transmission cycle. Then we also have something very strong in the region of the Americas, which is the cross-border and regional dynamics. We have many borders in South America where workers will actually cross the border every day to go and work in mining or other kind of industry. This has some quite important impact in prevention and control of yellow fever, and there is a need for regional collaboration and information sharing for effective monitoring and coordinated responses to outbreaks. I will explain that a little bit later in the way forward. In terms of the response that the countries are implementing in the Americas, Alvaro will speak about the yellow fever vaccination programs in the countries. We also have, of course, mosquito population control with interesting initiatives that are being led in various countries, health promotion among at-risk populations. We do not yet have strategies oriented to workers, but they are more oriented towards migrants and people living in at-risk areas. In terms of surveillance and early detection among human, we have regional guidelines that have been developed, but there is a need to strengthen these capacities to control yellow fever in the Americas. And we are working on zoonotic surveillance among non-human primates as a sentinel for what will happen in the human population. Next slide. So in surveillance, there is a strong effort that has been done in the past years to support the laboratory network for arbovirus diagnosis in the Americas, which is called RELDA and is coordinated with the effort of Dr. Jairo Mendez from our team. This includes 30 labs in 26 countries, and we have 5 WHO collaborative centers in Argentina, Brazil, Cuba, Mexico, and the USA. So this laboratory network is a laboratory network for arbovirus diagnostic in general, and most of them have both molecular and ELISA platform for arboviral disease, including yellow fever in endemic countries. Next slide. Strengthening the laboratory network is a priority for us. We want to maintain both serology and molecular capacities in all of our labs. and we work with CDC for trainings on these aspects in our South American region. We're also working on supporting countries in detecting sylvatic cases. So by doing training in virus detection in mosquitoes, but also doing training in detection in non-human primates, and this is really something where we try to use this Pan-Americanism and make sure that countries can cross benefits from other countries' knowledge. We're also working on harmonizing protocols for serology at the regional level, but also supporting countries to harmonize that within the countries, because we do have countries that are using different kind of approach according to their country to their counties. Sorry. And finally, I think one challenge that we have in the Americas is to be able to put yellow fever forward as a priority when we have massive outbreaks of other arboviruses, such as dengue, for example, and emerging ones such as the equine encephalitis or puche. So we're doing our best, and we're trying to work really in this network, integrated network of laboratory working on arboviruses. Next, please. Oh yeah, some other work like this that's been done in the past year, and we will be retaking in the coming years, is a work on the yellow fever risk assessment at the district level. It's a collaborative work between PAHO, UNICEF, and various academic colleagues, using machine learning to map yellow fever risk using data such as precipitation, temperature, primate prevalence, but also data such as canopy loss and other ecological data. So the models that were generated based on this risk analysis and machine learning to generate this risk analysis data predicted pretty amazingly what happened in the past. The idea now is to try to see how we can implement that in a strategy to prioritize actions in the future. So this is a theme that we will take back this year, and I will detail it a little bit more later.
Good afternoon, everybody. Very happy and honored to be here. Regarding the vaccination strategies in the countries of the Latin America and the Caribbean, we have three main activities. So the nationwide routine vaccination of children, the preventive campaigns during inter-epidemic periods. You may see, of course, campaigns according to risk analysis and vaccination in phases due to the shortage of vaccines, of course. And then the vaccination campaigns in response to outbreaks or episodics. Next, please. So there you may see the recommendations of the TAG, the Technical Advisory Group of the Americas, and also the SAGE recommendations regarding vaccination against yellow fever. And you will recognize, of course, the universal vaccination of children in endemic countries at 12 months of age in a simultaneous way with MMR vaccine, achieving at least 95% vaccination coverage. The vaccination of at least 95% of the population above 1 year of age residing in zootic areas, urban, rural, and jungle, and vaccination for travelers to endemic areas, and of course to have a vaccine stockpile at national level for outbreak response. The current situation is that all the 13 yellow fever endemic countries have already included this yellow fever vaccine to their national vaccination schedules for children. We have still some countries that do the vaccination only in high-risk areas, but most of the countries are doing it in a nationwide way. It is important to notice that we, of course, have a strong routine yellow fever immunization programs and vaccination campaigns, but we still have challenges regarding this. Countries with areas at risk for yellow fever has been encouraged to continue to immunize at-risk populations and travelers based on risk assessment. You may see here a table that will show you the year of introduction of the vaccine and, of course, the geographic area where the vaccines are being administered. In the link that is showing at the bottom of the slide, you may find also a link to get into the web page where you may find some more information regarding vaccination in the region. Next, please. Here you may see what was going on regarding the vaccination coverage for the last 4 years, from 2019 to 2022. And you may see that the COVID pandemic really hit on the vaccination coverages in most of the countries. Some of them have achieved to recover some of the vaccination coverages and even improved to what happened previously to the pandemic, but most of countries have had some problems with the vaccination coverage. Next, please. Also, this slide will show you the vaccination mean coverage in the region, comparing MMR1, so it's the measles containing vaccine, and the yellow fever vaccine also. And you may see that there is a very important gap between yellow fever and MMR1. And that is due mainly because some of the countries changed the age of vaccination of yellow fever. Instead of administering this simultaneously with MMR1, most countries did a different age for the vaccination. So MMR1 at 12 months, and some countries moved the yellow fever for the 15 months or the 18 months age. And this really impacted in very important countries and big countries in order to have this gap between the two vaccines. And it was due to the fear of the countries of this interference that may arise because of the simultaneous vaccination with the two vaccines. Next, please. So regarding the situation, the TAC made some new recommendations, recent recommendations in 2019, and it stresses the importance, of course, of achieving yellow fever vaccination coverage levels of 95% in endemic areas through optimal routine immunization and campaigns where indicated. In view of the available evidence supporting co-administration of the measles-containing vaccine and yellow fever vaccines, and the experience of increased drops out when yellow fever vaccination is scheduled beyond the 12 months of age, the TAC recommends that both vaccines be given during the same visit at the 12 months, but nonetheless, still some countries are separating both vaccines. If administered separately, of course, they should be separated for weeks. TAC recommends that further research be conducted in the region to examine the effect of lower antibody titers against rubella, mumps, and yellow fever observed after co-administration on long-term immunity. Next, please. So we are, with the help of CDC, we are conducting these research studies on neutralizing antibodies against yellow fever in children of 4 to 7 years after vaccinating the pediatric population, simultaneously with yellow fever and measles-containing vaccine. And right now, samples are being analyzed in the CDC, and we hope that this year we will have some reports or information on what's going on immunity regarding this simultaneous vaccination. And also, we have been implementing this programmatic assessment of vaccine provider perspective in order to identify barriers to yellow fever vaccination in South American countries. And we are already also analyzing this data, and we hope we will have some important information to help the vaccination program through the region. So this was for the routine immunization. Now, about the catch-up vaccination campaigns, the next slide, please. You may see that the last one that was implemented is the one in Venezuela, and it was planned in 3 phases. And you may see there by colors the 3 phases, phase 1, phase 2, and phase 3. And in the phase 1, it was targeted 4.7 million in 10 high-risk states. Then the next phase was 6 million people in 9 moderate risk states. And then this year and the next one, they are implemented the vaccination campaign in 1.8 million people living in low-risk states. It is important to notice that in 2021, after the campaign began in high-risk states, especially in the Monagas state, they identified an outbreak there, and it was related to an episodic in the area. So thanks to the vaccination campaign, even though the episodic continued, they didn't have any more cases of yellow fever within the human population. Next, please. Also, it's important to mention Vaccination Week of the Americas because it is also being used as a platform to promote yellow fever vaccination in the region. And many countries have been reporting the activities that they were conducting during this umbrella of the Vaccination Week of the Americas. Of course, you may see there the names. Next, please. And regarding the outbreak response, we may also here have the example of what happened in Brazil, where you may see that, of course, the need of this outbreak response vaccination was needed in the last big outbreak they had, of course, because of the magnitude. And I'm sure in the next presentations, they will be able to share with you more in this regard. It was a very, very important lesson learned for all of the countries in the region. And the next one, please, and the last one on the immunizations. It's to show you some of the vaccine forecasting. This is without Brazil. And you may see that for the next 3 years, including this one, the region is planning to buy around 40 million doses of vaccines in order to maintain the routine immunization activities and also to conduct some vaccination campaigns, especially because many countries have not implemented any vaccination campaigns during the pandemic and in the years previous to the pandemic. So this is something that is very important for us in order to try to identify the sources to get enough vaccine for these activities to be implemented, following, of course, the main objectives of the eye strategy. Over, Mark.
Thank you, Alvaro. Next, please. I will speak about the way forward, and I will go directly to the next and next again. I think we're a little bit behind schedule. Next, please. And next, yes, here. Great. So we drafted a regional roadmap, and it's still being drafted. But basically, the idea is to run a review of the guidelines for yellow fever at the regional and the country levels. This is something that we are starting now, so we are sharing memos with the countries to be able to see exactly what is being implemented at the country, both in terms of immunization as well as in terms of surveillance, lab, epi, and among non-human primates. We are this year going to establish a regional expert consultation group, so an ad hoc consultation group, in order to guide to guide us to create a regional roadmap and a regional yellow fever strategy. So this year we hope to have a regional meeting based on which we will develop a document supported by this group of experts. We hope to include in this document updated surveillance and immunization guidelines, and also work on an updated research agenda in order to identify funding options. We heard from Alvaro that we have like various operational research activities that are being held on immunization, and I think we may have the same kind of operational activities, operational research activities that can be held on other topics as well. We're also working on retaking the risk assessment methodology and tool in the Americas using the 2019 collaboration outputs, but also being proactive in the risk assessment working group and we'll have a meeting later today on that. Sorry. So the idea is to be able to have a user-friendly yellow fever risk assessment tool that can be used at the national and regional levels to guide decision making. Next, please. In the medium term, we hope to build regional guidelines and local capacities for integrated human, non-human primate, and vector surveillance of yellow fever to prevent human cases. The idea there is to strengthen the use of episodic surveillance in the region, and again use countries to co-train each other. We would like also to pilot project the implementation of an application for episodic notification. There is a very interesting one that is being used in Brazil, and some other countries could benefit from this experience. And run integrated surveillance training under a community-based surveillance approach. We have actually fundings coming from pandemic funds and the World Bank to work on community surveillance, and we will probably be able to use yellow fever as one of the case study for community surveillance. We will work on supporting countries to conduct immunity gap analysis to prioritize vaccination activities, and sorry, I'm speaking too fast. I thought you would tell me to go faster. Okay. And use the eye monitoring strategy dashboard to better prioritize actions at the country level. So this is something actually we discussed today in a meeting between the eye secretariat and PAHO, and we really want to make a better use of this tool. Last, please, or next, which is the last. And finally, in the long run, we want to strengthen entomological monitoring capacity at the country levels by having long-term training in entomology on sylvatic vectors. We will also work on urban preparedness planning and other risk reduction efforts, both to prevent potential urban outbreaks due to urban cycles, but also to prevent urban context outbreak due to sylvatic transmission cycles. And finally, to do all of that, we need to find resources to strengthen human resources, because we know that this is one of the big issues that we have in the region of the Americas, and I think here as well is a lack of human resources at the local level to be able to implement these strategies. Thank you for your attention. I think we conclude here.
Like to thank all of our speakers. We do have time for a few questions and answers. We also will be monitoring the chat. So if you are online, feel free to put your question in the chat. So I'd open it up for any questions for Laurence regarding the Global Eye Strategy. Also for Maury and sorry, getting tired here, on the Africa strategies, and also to Mark and Avril for any of the questions on the Americas and the yellow fever. Oh, question.
Yeah, it's a quick one. I have a question. It's not a question, but the application you are piloting for episodic notification in PAHO, is this application will be linked to the national surveillance system or not?
So we are not piloting that yet. It's the plan at the midterm. In the midterm perspective, the country that is using that is Brazil. I don't know if you want to comment on.
I'm also very interested in, because we wanted to do maybe the same in Afro, so we will see how to collaborate on this.
I think we can facilitate that. My understanding of this app is that it's really something to report on like suspicious death among animals that can then be investigated. But there is no link between this data and the national
surveillance system, because in Afro region, for example, we have a number of tools and what we call even EADSR. We are using in some country DHS2 or something like this. So I think it would be very good to have a link between these
application to the national system. So we will be able to capture, the information in one single system. You see it. So my second question is, can you go back to your slide where you presented like the episodic? There was a graph on the human and episodic cases. So I saw something very strange there. So I wanted to know, because in this slide, I think I saw somewhere some cases in primates, coming after human transmission. So is this mean that the transmission was in the other side or not? So this is my question. I don't know if
So, yeah, I think you.
Number 6. You go by.
The next one.
Yes, the 2019 season. You see the red one.
Yeah.
The cases came after the human transmission, so that's why.
Yeah. So the key message here is that it usually comes before.
Exactly.
I think we need to take into account as well the sensitivity of the episodic case detection, which is really. It really depends on where it happens, the capacity of detection in this district. Some districts are better equipped to detect cases in non-human primates. So it's the key message here is that it's usually before. There is I think absolutely no evidence that the transmission among primates could come from a primary. That's even it's so that. The right part is more problem of sensitivity of the surveillance among non-human primates.
Thank you very much for the presentations. I have the comments for the Africa and a question also for you. Since the first partners meeting, there's one sentence that keeps coming up on the African presentation. It says no grant or yellow fever control funding in Africa. It has been repeated every time we have had that meeting. What's the progress? Well, is there anything coming from Africa? We said it every year in, year out. And what are we doing about it? That's number one. Number two, I saw you didn't make any comments about issues of climate change on yellow fever in the African region. The issue of One Health, you talk about entomology studies and all that. What are we doing about that aspect? Thank you very much.
I will start. Okay.
Okay, I think you mentioned two critical points. The first is real. We are facing this funding issue. It's not new, but as we are here with partners, so that's why we wanted also to make this call, and we are working, with partners and with our resource mobilization officers to make sure that some more additional resources are mobilized to implement, this second phase of the ICE strategy from 2023 to 2026 or maybe 2027. Regarding the climate change aspect, of course, this is a very important, and we are now, it's not yet well established, and we don't have any models where we have like climate change weather data used to do a prediction or modeling. But we have started, and we have just recruited one epidemiologist specialist in what we call artificial intelligence and machine learning or something like this. So we are working on this. I think it's very critical, but we are not yet there, but we have started. Maybe you can compliment.
Yeah, thank you, Prof. I think one of the the areas that we are working with member states, I said it in the development of their national immunization strategy, making sure that yellow fever is well placed in those plans, so that when resources are mobilized, either domestically or from outside, we have support for yellow fever activities. That's at the country level. But at the regional level, as Maurice said it, I think efforts are being made wherever proposals are developed or wherever advocacy for resource mobilization are made to make sure that we mobilize as much resources as we can at the regional level to support yellow fever activities. So about the climate change, as just Maurice said it, I think there have been some efforts. I know, for example, with for meningitis, we are working with some meteorological organizations to do some predictions in terms of when or where we can have outbreaks of meningitis. So that same of efforts is also being extended to some other diseases, including yellow fever. Thank you. And cholera, yes.
Thank you all for the very nice presentation. I just wanted to follow up with Alvaro on one point on the co-administration of the yellow fever with the measles vaccine. You mentioned that some of the countries are observing the 4 weeks interval, right? Is there a practice where we are seeing that they are kind of giving importance to one vaccine over the other?
Thanks for the question. What is happening is that some countries decided to separate the administration of both vaccines, not by 4 weeks, but even for some 3 months or even for 6 months. And of course, it's note that it is not that one vaccine is more important than the other, but most people are used to get their children vaccinated by 12 months than after that, at least in the region. So all the vaccination that occurs after 12 months always have a lower vaccination coverage, even for all the other antigens. So this is something that this is a big challenge we have in the region, because we need to fight or to try to strengthen the vaccination at the 18 months for the reinforcement for the boosters, for polio, for example, because it's lower, for the DPT, for, of course, the yellow fever, if the country is administering the vaccine at that age. So it is not that they are preferring one vaccine over the other, but that the people is more used to get their children to vaccinate at certain ages. And most of the routine immunization activities in children are facility-based. Then this is some of the problems or challenges we have. I don't know if that answers or.
Any more? Did you have a question? No.
Two aspects to collaborate. First of all, in Brazil, during many years, people were trained in epidemiology and laboratory investigation, especially in episodics. And we know that monkeys, differently from Africa, they are susceptible to yellow fever. And we have a window of opportunity to investigate the monkey's death. And in Brazil, because monkeys can die of rabies, toxoplasmosis, herpes, and so on. So we together with the Ministry of Health, PAHO, and the reference laboratory for arbovirus in Evans Chagas Institute performed several training investigate the death of monkeys. And of course, this is facilitated to give a quickly response to the monkey's death, especially if the positive results for laboratory investigation is for yellow fever. So this is short the time between since the death of the monkey to implementation of the control measures. So just to clarify, another comment is from the Africa. I have observed a long delay between the index case diagnosis and the implementation of this. And of course, this is of concern because if the case is index case is occurring in general 2 months before the initiation of the investigation, this is too late to make preventive measures with efficacy that you think that is necessary. I think that it should be efforts to shorten this time between the index case diagnosis and the implementation of the control measures.
I think we do agree with you. Even I think yesterday, or it was yesterday or this morning, we were discussing with Marie-Ève, for example, for Cameroon. And, Cameroon reported one confirmed cases, I think now 6 months ago. Normally, we were proposing maybe to conduct a campaign, but we are not sure if the application will be approved, because usually, if the case is reported more than 6 months, the application will not be approved. So we fully agree with you. It's a very big challenge in the Afro region, and we are working on it to make sure that, to shorten this, time between the notification, the reporting. But the issue is about funding, because in most of the countries, we have, for example, for polio, we have funding, and the reporting system is functioning very, very well. But it's not the same for yellow fever. For example, if a suspected cases are reported, is reported in one remote rural area, and they have to wait for maybe until one suspected cases of polio is reported to have this sample sent to the national lab. You see, so there are some delay there, and we are trying to find a way how to shorten, but it's all about funding issue. But of course, we are encouraging our member state to integrate as much as possible the different surveillance system to make sure that we are utilizing, a polio surveillance system for yellow fever, not only for yellow, but for meningitis or other vaccine preventable diseases. Maybe, I don't know if you want to complement or if it's okay.
I think it's not only the funding. I think it is the government decision altogether.
Yeah.
In the endemic area of yellow fever.
Of course. It's one of the points I also mentioned this morning. And I think maybe some people can confirm. And I was saying, as partners, we rely on partners to support government, to strengthen the systems, the surveillance system. But if we want to have sustainability, of course, the government itself has to put money and to invest in the system. Otherwise, I think it will not function. Yeah, I fully agree with you.
All right. Just want to check real quick. There's nothing in the chat in terms of questions. Okay, nothing. So I'm going to turn you over to coffee break, but I am going to ask that you come back at 5, least you spend the rest of your evening with all of your friends in this room. So come back timely after the coffee break at 5, and we'll have 3 more presentations to wrap up the day. Thank you. I'm going to gladly announce our next speaker, who is Gum Mezang, who also is going by Gum. He is in the ICE Secretariat and is the program manager, and he's going to talk about the ICE accelerated implementation and multi-year plan and the mid-tier evaluation. Over to you, Gum.
Thank you, Erin. And Raki, could you proceed to the next slide? So this very brief presentation is going to present the background to the 3-year action plan, which is a result, the key output from the strategy's midterm evaluation. It's going to present the components of this plan, and it's going to present the next steps of the plan. Raki, could you proceed? Okay, so we start with this independent midterm evaluation to the I strategy. As you all know, this strategy was developed in 2017 with aim to run from 2017 to 2026. So the 10-year strategy at its midterm around 2021-2022, there was a need to evaluate the progress and identify areas for course correction and improvement to enable successful implementation of the strategy during the 5 remaining years and successful attainment of high strategic objectives by 2026. So an independent organization was contracted and selected via a public tender on the UN global marketplace. And this firm ran this evaluation with the 3 aims you see on the screen. So the first being documenting key achievements, best practices, challenges, gaps, and areas for improvement in the design and implementation of the strategy. Secondly, identifying key contextual factors and changes that were and are affecting yellow fever spread and transmission risk profile and influencing program implementation. And then the last, which actually results in this multi-year action plan, was making recommendations as appropriate on the way forward to improve performance and implementation, in addition to ensuring sustainability in the future, and of course for the global yellow fever prevention and control landscape beyond 2026. So this evaluation resulted in 8 key findings, and in response to these findings, 8 major recommendations were formulated to address each of these respective findings. So this is an overview of the 8 key recommendations. These recommendations were published globally, so they're available on the WHO website, and I think they were co-published across the core partner agency websites and other platforms. So the first had to do with the capacity requirements at all levels. The second was relaunching the strategy for renewed political commitment. The third was expanding and diversifying the governance structure. The fourth was scaling up of key interventions to reach undeserved, high-risk, hard-to-reach communities and at-risk workers. The fifth was improving integrations and synergies for maximum impact. The sixth had to do with supply chains and complementary activities to mitigate the risk of inadequate vaccine supply and improve surveillance and response to outbreaks. The sixth was on revising the strategic monitoring and evaluation framework. And the last was basically a concrete plan to ensure these implementations were implemented throughout the 2024 to 26 timeline, and also preparing for the global landscape post 2026. In the next section, so as a result of these recommendations, the I leadership group, which is the top entity at the top entity at the I-governance framework accepted all findings and recommendations from the evaluation, while providing further clarifications and detail on what their interpretation was on those recommendations, and what efforts they would aim to take to successfully address them. As next step, the leadership group assigned the responsibility of defining key actions to ensure that these recommendations were successfully implemented. This was assigned to the I Program Management Group, and this was done via the Management Response Plan. So we had the first version and we had the second version. And the last step, the I Secretariat was tasked with supporting the I Leadership Group in, with supporting the I Program Management Group in developing a 3-year action plan, which would have aimed to ensure that these actions were successfully implemented by 2026. So the 3-year period from 2024 to 2026. So what has been done as of now on the preliminary version of this plan is that these recommendations have been summarized into key themes. And on each theme, you have key expected outcomes that will, if attained, would ensure that the recommendations are met. And in order to attain these outcomes, there are key outputs and deliverables that need to be produced or delivered. And in order to attain these outputs, there are key activities that need to be implemented at multiple levels: national, regional, and global. So the next slide aims to present a high-level overview of the key themes that resulted from the midterm evaluation. So you would see 8 major themes here, one of each of which tries to reflect or summarize what the scope of each recommendation is. Of noteworthy importance, for example, would be recommendation 5 on 8, which is in pink, and that's enhanced integration and synergies for maximum impact. And under this recommendation or theme, you have 4 major expected outcomes. So the integration component is being split into an immunization part, a surveillance part, and then the other parts around synergies for maximum impact. In addition to this, there is recommendation 4 and 8, which you see in light blue, which has to do with scaling up of interventions. Again, scaling up interventions to protect these vulnerable populations. And so of noteworthy importance, we will talk of all the actions to reach vulnerable populations, at-risk workers, and complementary actions and efforts. So here you would see, for example, piggyback activities and leveraging activities targeting zero-dose children, or using yellow fever interventions for such interventions. You would see other interventions anchored around outbreak root cause analysis and immunity gap analysis, and complementary recommendations and expected outcomes and key priority areas. So the next slide. So what we are doing anyways at the level of the I Secretariat, and in response to the request from the Program Management Group, is that we try to transfer these key recommendations into a tool. This was mainly to facilitate tracking, assigning roles and responsibilities, and then implementation, at least at the level of the key I governance entities. So the delineation is, as you see here, you have the 8 key recommendations. And then on the next slide, you have the expected outcomes. For example, if I was to take recommendation 5, which is on integration and synergies, you will have key, I would say, sub-outcomes, which cover immunization, surveillance components, and others. And then on the next slide, if we were to go deeper into the integration recommendation and its expected outcomes, you would have a set of outputs, basically from consultative sessions to planning to leveraging under surveillance. For example, we have DHIS2 and so on and so forth. So you have the key outputs, and for those outputs, of course, to be attained, there would be need for work planning and further work breakdown, so that we can define across the partnership and across across our various partner agencies and working groups, we can define key activities that we would implement on a monthly, on a quarterly, on a semi-annual, on an annual basis, to ensure that on a year-to-year basis, we can make progress towards attainment of these goals. So if we were to move, and you see on the last section, you see key focal persons. For now, you see pictures, but basically that's just an example for the Secretariat focal persons who support some of these areas. But again, this spreads across the partnership. On the next slide, which should be the last. So you have a sort of timeline which tries to present the most recent progress that is being or has been made, and basically the next steps to close or to finalize this plan and to proceed with implementation. Of noteworthy importance is that implementation of these recommendations, I would say, started back in 2023. So the idea wasn't to wait for this plan to be completed, but to start with course correction immediately. So there's been mention of a lot of root cause analysis, immunity gap analysis activities to target at-risk workers, and complementary interventions. At the level of integration and synergies, I could easily quote the nationwide yellow fever campaign in Chad, which should be integrated with the measles and was launched, I think, in February, and so on and so forth. So most of these activities are already ongoing, but this will provide a framework to support them and to facilitate planning and, I guess, prioritization. So as of now, we are basically at the stage of presenting this version, which of course was endorsed by the I Program Management Group. We expect to finalize this by June, and by the next month, we would present this to the leadership group for validation, and implementation has already been ongoing. At the level of some working groups, for example, the risk analysis working group, they have already had discussions on their work plan for this year. So they did their best to integrate some recommendations from here. And at the level of the regional teams, that is more or less what is going on. And even at the level of the I Secretariat. So I would say this is work in progress, and the aim is not to wait for this finalized plan, but the aim is to ensure that as soon as we had these recommendations and they were accepted by the leadership group in, I would say, last year, implementation was immediately kicked off to address them. Thank you, and the floor is open for any questions.
Thank you so much, Goom. We will go on to our next presentation and take questions at the end of these three presentations. For people online, don't hesitate to put your questions in the chat. So I am very happy and very privileged to turn over the floor to Makamu, a good colleague of mine. We spent many, many weeks and months discussing yellow fever risk and defining that. He is the EPI manager here in Ethiopia Ministry of Health. Over to you for a country presentation for the I implementation strategy.
Thank you for your kind introduction. I appreciate. I appreciate how you express the contributions, but I'm new for the immunization in general, and I have a little experience actually. So I appreciate the introduction. So as Ethiopian, our primary objective here is to learn from other countries who previously implemented the recommended interventions before us. So despite the delays that to introduce the vaccine and other interventions, I can say that we are lucky to learn from others. So here, we are here to introduce and to update you some of the efforts made as Ethiopian government. So I'm very happy to be here to speak on the behalf of the Ethiopian team. So I will give you some background information about the country and the yellow fever disease, and again the I strategy implementation status, and the next steps, and key support areas that we want to discuss with you for our implementation. Next. As you can see from here, Ethiopia is the second largest country next to Nigeria. Based on the estimation, the in-country estimation, there are more than 109 million population. Actually, based on the UN estimate, the total population is close to 129 million population. And administratively, it is divided into 12 regions and 2 self-administered cities, and 86 zones and more than 1,000 districts. So most of the population is resides in the rural, which is 83%, and it's a large in the area which accounts as 1.2 million square kilometer. When you see the health facility structure, we have about 22,000 health facilities that are expected to provide immunization service and surveillance, and most of them are at the primary healthcare service, which is accounted by health facilities and health posts. Next, please. Okay, thank you. So to give you some introduction about the vaccine introduction and key achievements in Ethiopia, we launched the expanded immunization program in 1980, and since then, we were able to introduce most of the recommended vaccines in Ethiopia, and currently we are providing about 13 antigens, including COVID-19, in the routine immunization program. So having this, we are certified for polio virus and validated for the elimination of maternal and neonatal tetanus. Multiple new vaccines are in the pipeline for the introduction, including the yellow fever, hepatitis dose, many and others. So we can say that among those vaccines which are recommended to be introduced up to 2030, most of them are introduced, and we are also using some vaccines like yellow fever, many, OCV, hepatitis B for outbreak responses. Next. To show you some progresses in the immunization coverage, for example, taking into Penta-3, you can see that up to 2019, in all sources of data, I can say that it was in a good progress to achieve the global and national targets. However, after 2019, it shows some decline in stagnations. So, in addition to the progress, you can see here that there are some data issues and some variations among those sources of data. So the one which is orange one, you can see that it's administration report and it is high in coverage. But when we try to see the unique surveys, other surveys, it is beyond that, and you can see that there are suboptimal coverages. The data issue can be verified using those how we are now implementing using these data by triangulating the data for our decision. So you can see from this that we have high zero dose children and disruption of services due to different conflicts, COVID-19 pandemic and droughts, shortage of resource to sustain the gains from the routine immunization in the surveillance is also other challenge that we have. Please proceed. Yeah, thank you. To see some epidemiologists and about the disease and the eye strategy status, Ethiopia is categorized as a high risk country for yellow fever, and you can see that that since 1950s there were different outbreaks in different times, and to show you some of the recent outbreaks and managements, there were that actually the first case was 1959 and the recent one in 2020. So you can see that since then we were, the number of cases experienced in Ethiopia were 117,000, and the number of days we have were about 30,000. So we had, a case fatality of 26%, and you can see that the epidemiology and the prevalence is not evenly distributed in Ethiopia. You can see that the southern west part of the Ethiopian is mostly affected by yellow fever. Next. Yeah, based on the subnational risk assessment in Ethiopia, you can also see that, some of our question was, by the time, since yellow fever was not evenly distributed, we want to see that how it is, distributed within the country, and actually this will also help us to introduce the phase-based vaccination campaign. So based on that, we categorized the country into 14 areas, and based on that, most of, we can also confirm that all of the areas were actually at risk, but it varies. The level of the risk was varying, and it also confirmed that the southern western part were also, with high risk, which includes the SNN PR, Oromia West and Oromia Southwest, Sidama, whereas with high, high risk. So it's expected that we will start from these regions the vaccine. Next. So to show you some, data and information about the status of the eye strategy. As you all know, there are three strategic recommended objectives of the eye strategy. The first one is protect at-risk population, and the second is prevent international spread, and the third is contain outbreak rapidly. So to show you this, I will take you through some to the status of some activities, interventional activities in the country. Next. The first intervention and activity to be implemented for that was surveillance and diagnosis. So in Ethiopia, we established the FEM system, and we have a clear guideline, SOPs, and surveillance and diagnosis system is well established with a clear guidance and guideline. And yellow fever is part of that. Actually, since 2012, it's part of that, and it is one of the immediately reportable diseases in the Addis. So all arbovirus suspected specimens tested for yellow fever, and actually since 2020 we have 0 reports, as you can see from the regional reports. We have 0 reports, and we also conduct point-entry screening and vaccination. We also, follow the neighboring countries' situation, and following the alerts that received from neighboring countries, we are also, conducting preparation activities. For example, the South Sudan case was, alerting us. Thank you. Next slide. So the second one is conduct reactive vaccination campaign in affected areas. So historically, we conducted 3 campaigns, which was, in South Omo zone in 2030, and Walaita zone with coverage of 100%. And again, we conducted the last case outbreak situation in 2020, and we conducted a reactive campaign with 97%. We also, conducting travelers vaccination, and we are, able to vaccinate thousands of travelers during the entry, and again during they travel to other countries based on the requirements. Next. Yeah. So the other recommendation is the inclusion of routine immunization, yellow fever to the routine immunization and conducting the mass vaccination. So based on that, I will try to show you the efforts that we made to introduce the vaccine. So the first thing that what we do is just gathering information and for our decision making. So one of the activity was conducting seroprevalence survey that showed evidence of yellow fever virus circulation in 3 out of 5 ecological zones. And again, we also, conducted different reviews, desk reviews, and expert opinions. And finally, we were, planning a 3-year, plan to implement the I strategy. Following that, the Ethiopian NITAG recommends the introduction of yellow fever into both RI and preventive mass vaccination. And then using this recommendation, we take this to the ICC, and the ICC actually recommended to have some, additional information about the subnational risk level. So having this, actually the introduction of vaccine was part of our national plan, but unfortunately, in the meantime, there was in 2019 there was the occurrence of COVID pandemic and different conflicts in our country, and there was also drought in some of the countries that leads the displacement of some of our populations. So it was unfortunate that it was not implemented as planned. So what we did is, during the revision of the full portfolio planning, Gavi, we tried to revise the planning plan to introduce the vaccine in 2025. So in the meantime, we were also conducting some subnational assessments and ecological, scoping studies to identify and to characterize the level of risks at some national level and to identify which strategy is better for us. We had a question that is it something that we introduce nationwide or subnational was our question. So based on that, the ministry RAC Research Advisory Committee conducted the scoping study and recommended that a nationwide introduction is recommended, because some experiences also showed in Kenya that it will be difficult to achieve the elimination if we introduce the subnational level. So these two, the subnational risk assessment and the scoping study, helped us to get more information. And having this, we again reinitiate the discussion with ICC. In the meantime, the I Secretariat also conducted, during the dissemination of the subnational yellow fever assessment result, there was an advocacy meeting with the ministry and the in-country partners. So I appreciate that. Actually, that was a very critical meeting that we had, I remember. So based on that, we put action points and take this to the ICC, and the ICC endorsed the introduction of routine yellow fever to the routine immunization and a phase-based preventive mass vaccination. So currently, we are preparing the vaccine introduction documents, and we're planning to introduce the vaccines based on the available resources. Next. So based on our preliminary data that we have during the plan development, we have 3.2% of our population, which is about 3.7 million for targets for the routine immunization. And again, we have about 115 million targets for the preventive mass vaccination, which is actually close to the entire total population of the country. So it's a huge number. You can see that. So we understand that we will not, be able to implement this once. So a phase-based introduction is recommended. So the first in 2025, we are proposing to address near to 30 million targets, and it will continue up to 2029. So you can see that it is a huge target that will challenging us to cascade the phase-based implementation of the preventive mass vaccination. Next. So based on our understanding, we can say that the first objective is we are in a good preparation and promising because we are preparing for the introduction of routine immunization and preventive mass vaccination. So where we feel that we are behind, but we are in a good position now because we are preparing for that. The second objective, we are implementing some of the activities, so I can't say that it's under implementation. And the third objective is also in implementation because, as you can see from my presentation, we are conducting surveillances, entry point screening, and testing. Again, vaccination. Those are part of that, and we also implemented outbreak response. So we are implementing those, but we have also some gaps and challenges to strengthen the surveillance and laboratory capacity. Next. So as a way forward, finalizing the yellow fever vaccine introduction application will be our immediate task, and then introduction of yellow fever into the national routine immunization program and phase-based implementation of the preventive mass vaccination will be our next priority. Yellow fever outbreak response is also a very, very critical area that we will, implement, improve the quality of the yellow fever case management, screening, laboratory surveillance, and expanding the diagnostic capacity particularly at sub-national level. We have challenges even in the national level, but we believe that it's good to expand to sub-national level because Ethiopia is a large country. So other technical supports, training, supportive supervision, monitoring and evaluation will be also our next steps. Demand generation, risk and crisis communication will be one of our critical area because, as I tried to mention, this is not evenly distributed in the country. It's not known in some parts of the country. But I mean that I'm talking from the perspective of the perception of the community, not from us. So I expect such hesitancies during the introduction. So much work is expected from this side. Resource mobilization for the I strategy implementation is a critical point. This will be one of the factors that expedite the time of introduction. Though the government of Ethiopia, as you can hear from the opening keynote remarks, we are deciding this critical step, passing through different challenges. Just we are trying to, reflect our commitments by endorsing and including to the national, strategies, and we are, trying our best. But the more we get the supporters, it will expedite the implementation time. Next. So this will be our, few key support areas required from our partners. The first one is provide financial support for both array and the preventive mass vaccination that is supposed to reach 95% of the population. So as we try to, highlight during all of our, discussions, I can say the covering the co-financing for Gavi. Yeah, no, Ethiopia is Gavi eligible country, Gavi supported country, but since we introduced several vaccines and the co-financing is becoming high, and given that we have some vaccines that we procure by ourselves, we are challenging, to pay even the existing vaccines to cover the co-financing. So what we are, trying to do is to get support from our donors or other partners that can cover the co-financing on the behalf of the Ethiopian government for the time being, at least for some time. We are proposing for 5 years is a critical support that we are looking for. The other thing, through our experience, Gavi is actually providing operational cost supports to countries. And in our experience, what we understand is the cost of living and implementation costs are increasing, and we understand that the Gavi support is not enough. We are challenging on this. Historically, we think that since it has a Gavi support for operational, it's okay to introduce, and we practice that. But in doing implementation, we were challenged due to shortage of operational costs. So we also, look for those supporters that is over than the Gavi ceilings. The other one, ensure availability of vaccine and supplies required for both RI and preventive mass vaccination is a critical issue. Once we sometimes, create the demand and started the mobilization activities, it will be challenging to lose our trust to our community. We have experiences during the HPV. Really, we are disappointed on that actually. We introduced HPV in 2018. Since then, we were looking for support, for additional support to conduct the MAC. After 5 years, we get a promise from Gavi and others, to ensure to make avail the vaccine, and we started a huge movement in the country. Unfortunately, after we create this demand and communicate it to the media, and for every stakeholder, we couldn't get the vaccine timely. So this has some, similarity in my understanding. In Denmark, we were planning to reach up to 9 million girls, and this is also, a huge number. You can see it is more than 100 million. So we want to ensure that there is available vaccine for this. Unless otherwise creating such demand, there are different, sensitive issues in the country. I feel that we may lose our trust to our communities. So we want to be clear that there is availability of enough vaccine for that. Financial and technical support for surveillance and diagnostics, particularly, I said that I was trying to actually reflect some of the efforts that we did, but there are still some gaps in the surveillance, laboratory, and other activities. So we are looking for supports on these areas. So we are also planning as part of other health system. We are also, trying to increase domestic resources for this. And as you can see, the Ethiopian health system, there are, the health system structure is good, and we have health work forces, trained health work forces. Particularly, the health extension program is equipped with more than 40,000 trained health extension workers, paid purely by the commitment of the government. So we are trying to, ensure the commitments of the country, but due to other priorities and some issues in the country, we are looking for additional supporters. These are, I think, from my side. Thank you.
Thank you very much, Makamo. Again, we'll hold questions until the end. Just want to note our next presentation is going to be in Portuguese. So I would dust off your earphone unless you're fluent in Portuguese, or at least okay in Portuguese. And it's my pleasure to introduce Edagati Fernandez, Dr. Fernandez. I first met him when he was in the state of Sao Paulo and responsible for immunization safety, but since then he's been promoted to the director of the Department of Immunization and Immunopreventable Diseases at the Brazil Ministry of Health, and he'll be talking about the AMRO or PAHO regional experience with the eye implementation. Over to you.
Thank you very much. Hi, everyone. Well, I speak in Portuguese. For me, it's easier. So, I'm sorry. Bem, and I will speak loud and slowly. Eu vou falar sobre o plano que o Brasil tem para os próximos anos no combate à febre amarela. Next, please. E para eu falar sobre esse plano, eu gostaria muito de trazer a situação epidemiológica da febre amarela no Brasil e também falar da construção histórica que nós tivemos para chegar neste plano. Next, please. Next slide, please. Yes, that's it. Como vocês podem ver, o Brasil ele contribui, em média, com 10% da casuística de febre amarela global. Só que essa ocorrência de febre amarela ela não é homogênea ao longo do tempo. Nós temos picos de ocorrência de febre amarela no nosso país. Normalmente, esses picos acontecem quando a febre amarela sai da região amazônica e provoca surtos em áreas de baixa cobertura vacinal. E vale destacar, na história recente, principalmente depois de 2016, nós tivemos um aumento expressivo da febre amarela no nosso país, que inclusive tem como característica a identificação de vários casos fora da região amazônica. Próximo, por favor. Next, please. Diante dessa casuística brasileira, o Brasil, ao longo dos anos, ele acumulou um número de casos que coloca o nosso país em segundo lugar no mundo em termos de números de casos. Então, nós contribuímos com... hoje, nós temos acumulado 17% dos casos do mundo e 72% dos casos de febre amarela das Américas. Next, please. E aí é importante destacar que ao longo da história a febre amarela também mudou muito o seu comportamento no nosso país. Se vocês olharem nas barras pretas, nós temos a ocorrência de febre amarela urbana, casos em seres humanos. E desde o início do século passado, nós identificamos casos em primatas não humanos, que são as barras vermelhas. Que são as barras verdes. A gente começou a identificar casos em macacos e isso acabou no futuro contribuindo com a nossa vigilância. E por conta dessa ocorrência em primatas não humanos, as barras vermelhas, nós temos a ocorrência da febre amarela em humanos através do ciclo silvestre, ou seja, são casos acidentais, seres humanos que entram nas áreas de mata e acabam adquirindo a febre amarela. Mas uma coisa que é interessante destacarmos é que a partir de 1999, nós começamos a utilizar a identificação de primatas não humanos como um indicador preditivo da ocorrência da febre amarela, para que a gente pudesse, a partir dessa identificação, organizar estratégias de prevenção. E conforme foi passando os anos, a identificação de primatas não humanos ficou cada vez mais frequente, E uma coisa que é importante destacar, a ocorrência de casos humanos silvestres. Se nós considerarmos de 1932 a 2014, nós temos acumulados 2.260 casos em humanos causados pelo ciclo silvestre. Só que só no período de 2014 a 2022, nós superamos essa marca com 2.298 casos acumulados. E uma coisa que é bem característica, aumentou a identificação de casos em primatas não humanos e em humanos, e sempre ocorrendo fora da região amazônica. Próximo, por favor. Next, please. E nessa figura é possível nós identificarmos, mostrarmos o avanço da febre amarela no nosso país. Já em 2014, foi possível identificar um aglomerado de casos, tanto em primatas não humanos quanto em humanos, na região centro-oeste do nosso país. E a identificação desses casos ela foi avançando rumo à região sul do país, através dos anos de 2015, 2016, chegando em 2017, com a identificação do número expressivo de casos na região sudeste do país, inclusive com casos identificados na Mata Atlântica, ou seja, próximo da região litorânea do nosso país. Ou seja, a febre amarela ela atingiu regiões que previamente não tinham a indicação de vacinação e regiões que densamente povoadas, regiões metropolitanas concentrando pessoas não vacinadas. E aí, com o passar do tempo, se consolidou a presença da febre amarela nessa região, rumando nos anos seguintes para a região sul do nosso país. No ano de 2022 e 2023, a gente consegue identificar novamente a febre amarela no centro-oeste brasileiro, com uma nova linhagem, inclusive identificando aí talvez uma nova onda acontecendo no nosso país. Próximo, por favor. Next, please. Next slide, please. Então, como foi dito anteriormente, inclusive na apresentação do Mark, uma coisa que é bem interessante é que a identificação de primatas não humanos antecede de forma significativa a identificação de casos humanos. Então, aqui a gente olha, por exemplo, esse gráfico, o gráfico de cima, é possível ver a identificação da ocorrência de casos em primatas não humanos. E a gente percebe que nos meses de setembro, outubro e novembro aconteciam casos em primatas não humanos, enquanto no mesmo período nós não identificávamos casos em seres humanos que foram identificados a partir do mês de dezembro do ano de 2017. Ou seja, a identificação dos primatas não humanos representa um potencial preditivo importante. Então, nesse período, foi muito importante essa vigilância, porque mesmo em setembro, outubro e novembro, nós já estávamos preparando e colocamos em execução ações de vacinação e potencializamos a nossa vigilância, sabendo que nos meses de chuva do final do ano nós teríamos uma alta incidência, provavelmente em seres humanos, o que de fato se concretizou. E aí, o aplicativo que nós utilizamos para georreferenciamento dos casos em primatas não humanos é esse aplicativo chamado CISGEL. Ele é um aplicativo que ele não apenas está com os profissionais de saúde, mas ele também está na mão de pessoas que trabalham na agricultura e no meio ambiente, na identificação desses primatas e georreferenciando, ajudando a vigilância em saúde a identificar esses casos e iniciar um processo de investigação desses casos em primatas não humanos. Next, please. Só que uma coisa que ficou muito evidente no surto que aconteceu a partir de 2016, 17, 18 no nosso país, é que a estratégia de vacinação por município, ela consumia muita vacina, principalmente no momento em que a febre amarela chegou em áreas urbanas. A estratégia do Brasil anteriormente era vacinar o município afetado, ou seja, aquele que identificava o caso. Então, fazíamos uma vacinação tipo catch-up e depois vacinávamos os municípios do entorno. Com a experiência que nós tivemos, principalmente no sudeste brasileiro, aqui nós temos uma imagem de Google Earth, a gente pode ver alguns municípios e a identificação de alguns primatas não humanos que morreram por febre amarela. Next, please. E aí, considerando a posição desses primatas e considerando a existência de matas, ou seja, corredores ecológicos, e também considerando a amplitude de voo dos mosquitos e a velocidade de voo desses mosquitos, foi possível a gente traçar um caminho por onde a febre amarela caminhava. Next, please. Então, essa identificação foi possível a gente traçar alguns caminhos alternativos e depois esses caminhos acabaram sendo validados pela identificação de novos macacos mortos. Então, com isso, a gente poderia traçar, a gente pôde traçar todo o caminho que a febre amarela percorreu e validar também um modelo descritivo que permitia ter uma certa previsão de onde a febre amarela iria estar. Next, please. Então, utilizando os mapas, que aí nós conseguimos através das secretarias de meio ambiente, ou seja, os mapas de florestas, a gente pôde traçar, então, os corredores ecológicos que depois foram validados com a identificação de primatas mortos. Next, please. E aí, considerando que é possível saber a velocidade de voo, a velocidade de propagação dos mosquitos, dependendo do período do ano e dependendo das condições climáticas, foi possível também traçar um tempo e, com isso, prever quando que a febre amarela chegaria em determinada região. Next, please. Então, a partir daí, a gente pode, então, traçar os possíveis caminhos da febre amarela. Então, nas linhas vermelhas, nós temos ali corredores ecológicos, no mapa que está à esquerda. Corredores ecológicos que foram validados e identificados primatas não humanos. E na linha laranja, nós temos corredores que foram traçados num caráter preditivo, onde poderia ser o caminho da febre amarela. Então, nós conseguimos saber que a febre amarela atingiria a região metropolitana de São Paulo em alguns meses, e isso permitiu que a gente fizesse estratégias de vacinação casa a casa. Então, na foto que eu tenho, que eu mostro para vocês à esquerda, é a vacinação que aconteceu no município de Mairiporã, que fica acima do município de São Paulo, e essa vacinação ela aconteceu em agosto. A febre amarela ela foi identificada nessa região em outubro, ou seja, com 2 meses de antecedência, a gente conseguiu vacinar a população dessa região. Next, please. Então, diante do bom desempenho que essa estratégia preditiva teve, o Ministério da Saúde ele consolidou um grupo que nós chamamos de GRUNFA, né, que é um grupo que é um grupo de modelagem de dados e análise de risco preditivo da febre amarela. Então, esse grupo passou a se reunir com certa periodicidade, no sentido de fazer análise de risco e também definir locais prioritários para que as ações tanto de vigilância quanto de vacinação fossem realizadas. Next, please. Então, no ano seguinte, já no ano de 2019, no ano de 2020, esse grupo ele produziu uma nota técnica prevendo o que iria acontecer no sul do Brasil e também já traçando áreas prioritárias que deveriam ser intensificadas ações de vigilância e de vacinação. Então, teve um documento técnico que foi produzido antes de consolidarmos, de fato, um plano nacional. Next, please. O GRUNFA também foi responsável por traçar um plano de ação, né, baseado em uma análise de risco na região central do Brasil, a partir de identificação de circulação viral que aconteceu na região. Next, please. E também na região Nordeste, que a região Nordeste brasileira foi a última região com a recomendação de vacinação contra a febre amarela. Então, também utilizamos a mesma estratégia de análise de risco para definir as ações de vigilância nessa região. Next, please. Então, a partir desse conhecimento acumulado que nós tivemos com o surto que aconteceu de 2016 a 2019, nós produzimos um plano de contingência para resposta às emergências de saúde pública de febre amarela. Então, o grupo se reuniu, consolidou a proposta, e aí agora temos o desafio de, periodicamente, renovar essa análise de risco. Next, please. Então, o plano ele tem como objetivo desenvolver ações de vigilância e resposta. Então, ele inclui todas as entidades que fazem parte do nosso sistema único de saúde, do nosso sistema público de saúde e do nosso sistema nacional de vigilância epidemiológica, e ele serve também como norte para a construção de planos regionalizados. Next, please. Então, ele tem uma característica de considerar o período de menor ocorrência, né, que pega os meses de junho e setembro. Nesses meses, nós normalmente não identificamos primatas ou casos em seres humanos. Depois temos o período pré-sazonal, que pega de outubro a novembro, e esses dois períodos servem para preparar o sistema de saúde para o período sazonal, que pega normalmente o mês de dezembro a maio. Next, please. Então, durante o período de baixa ocorrência, que é no mês de junho a setembro, nós fazemos uma análise epidemiológica da situação e uma avaliação crítica do período anterior, e aí nós aproveitamos esse período para melhorar a nossa vigilância e o sistema de saúde, repor os estoques de vacinas e insumos necessários para a vigilância, treinamos os profissionais de saúde e avaliamos também a situação vacinal dos municípios, a cobertura vacinal dos municípios, para ações de intensificação da vacinação. E aí entramos, next please, no período pré-sazonal, onde nós fazemos a avaliação de risco. E aí na avaliação de risco nós definimos os municípios prioritários. Então, aproveitamos esse momento também para fazer o alerta a profissionais de saúde, coordenar os serviços de saúde assistenciais e também comunicar as áreas de maior risco, elaborar um plano de comunicação para as áreas de maior risco. Next, please. Então, a avaliação de risco que nós fazemos, nós consideramos como vulnerabilidades, a baixa cobertura vacinal e a baixa sensibilidade da vigilância por casos em primatas não humanos. Também consideramos a existência de vetores silvestres, né, o hemagogos e o sabetes, e também a infestação por Aedes aegypti na região. E, a partir dessa avaliação de risco, definimos as áreas prioritárias e, uma vez detectado casos em primatas ou em humanos, bem, aí nós já mudamos o cenário, pois estamos diante de um risco eminente. Next, please. Então, uma vez identificado um caso em primata ou em humano, e aí a ação ela passa por uma lógica de contingência. E aí a gente tem 3 cenários, nós trabalhamos com 3 cenários. O cenário número 1 é quando é identificado um caso isolado, e aí nós seguimos a lógica antiga, que é de vacinar o município onde foi identificado os casos e vacinar o entorno. Quando a gente tem uma identificação de casos de forma regionalizada, ou seja, vários casos identificados em uma determinada região, podemos podemos seguir com a lógica de vacinar o município e os municípios do entorno, ou podemos já adotar a estratégia de priorização considerando os corredores ecológicos. E aí temos o cenário 3, que é um cenário que temos a identificação de múltiplos casos em seres humanos ou em primatas, em áreas metropolitanas e de baixa cobertura vacinal e também de alta infestação de vetores. O cenário 3, eu vou detalhar ele na minha apresentação que eu farei na quinta-feira. Next, please. Só que é importante também destacar um novo momento que o Brasil vive, e isso daí o momento que o Brasil vive, ele vai exigir adequações do nosso plano. Aqui eu trago uma foto do presidente Lula sendo vacinado. É importante destacar que o novo governo brasileiro ele colocou a vacinação como uma prioridade, e nós lançamos o Movimento Nacional pela Vacinação numa lógica de mobilizar a sociedade em prol da vacinação. Então, temos o objetivo de recuperar as coberturas vacinais do nosso país, que caem desde 2016, então, estamos trabalhando para recuperar a cobertura de todas as vacinas, mas é importante eu apresentar isso aqui porque impacta diretamente nas ações da febre amarela. Next, please. Então, uma das estratégias que nós adotamos no nosso país para fortalecer a vacinação de rotina foi o microplanejamento para as atividades de vacinação de alta qualidade. Então, no ano passado, nós fizemos oficinas em todo o país e apresentamos as ferramentas do microplanejamento para os municípios. Então, demos recursos extras para os municípios, então nós disponibilizamos cerca de 30 milhões de dólares distribuídos para os municípios para que eles fizessem ação de vacinação fora das unidades de saúde, só que na lógica de fortalecimento da rotina. Então, apresentamos as ferramentas do microplanejamento. Next, please. E depois que nós fizemos a apresentação das ferramentas do microplanejamento, nós promovemos uma multivacinação, numa lógica de catch-up, em todo o país, para as 18 vacinas que nós recomendamos para as crianças e os adolescentes do Brasil. Então, isso aconteceu de forma nacionalmente e, inclusive, numa lógica descentralizada. Então, conforme nós apresentávamos o microplanejamento, na sequência, fazia-se uma ação de multivacinação. Next, please. Então, essa foi mais uma estratégia adicional a todo o rol de todas as atividades que nós desenvolvemos em vacinação. Então, vale destacar que, além do microplanejamento, nós temos uma operação que envolve a aeronáutica brasileira, com o objetivo de vacinar áreas indígenas e áreas ribeirinhas, ou seja, aquelas pessoas que moram distante, na região amazônica, e que não têm acesso à vacinação. Nós temos uma estratégia também de vacinação em fronteiras, que nós estamos avançando com essa vacinação, com essa estratégia em todas as cidades irmãs que nós temos, ou seja, aquelas fronteiras secas, que são fronteiras com cidades gêmeas de países vizinhos. Next, please. E aí, alguns números, nós melhoramos a cobertura vacinal no ano passado, quando comparado com o ano de 2023, passamos de 60% de cobertura vacinal para 68,5%. Nós tivemos entre os municípios que atingiram a meta um aumento de cerca de 400 municípios atingiram a meta de 95% de cobertura vacinal, e todos os estados brasileiros melhoraram a cobertura. Next, please. Só que nós podemos observar que a cobertura ela não é homogênea. Então, nós temos aí diversos... a gente houve uma melhora, nós conseguimos perceber, principalmente na região nordeste brasileira, uma melhora da cobertura vacinal. Então, vocês podem ver pela quantidade de municípios pintados com a cor escura. Next, please. Mas eu gostaria de destacar, por exemplo, a região nordeste, aí eu coloco um destaque no Rio Grande do Norte. Next, please. Esse é um estado que ele tinha uma cobertura vacinal muito baixa para a febre amarela, e ele foi o estado que nós fizemos a estratégia piloto do microplanejamento, e a estratégia piloto do microplanejamento ela foi direcionada para a vacina de febre amarela. Então, nós testamos as ferramentas do microplanejamento nos municípios desse estado, e aí a gente percebe que houve um aumento significativo na cobertura vacinal de rotina contra a febre amarela. Next, please. Então, assim, resumidamente, o que nós vamos fazer nos próximos anos? A gente vai juntar as duas estratégias, para ser bem objetivo com relação ao que o Brasil fará. Considerando o período de baixa circulação, ou seja, o período pré-sazonal estabelecido pelo plano de contingência da febre amarela, vai ser o momento em que haverá uma reunião, uma definição por parte do grupo de modelagem, e apontará para o Programa Nacional de Imunização quais são os municípios que estão numa maior situação de risco. E aí, no período pré-sazonal, nós promoveremos ações de vacinação na lógica do microplanejamento nestes municípios prioritários. Então, nós juntamos as duas estratégias. Então, todos os anos, faremos uma definição por parte do grupo de modelagem, seguido por uma ação de vacinação pré-sazonal, preparando os municípios com maior risco para o momento pro momento sazonal. E, paralelo a isso, também intensificar a vigilância, principalmente a vigilância de primatas não humanos, nesse período pré-sazonal, para que quando chegue no período sazonal, além da vacinação, a gente tenha garantido também uma vigilância sensível o suficiente para identificar casos. Next, please. Então, aqui tem os documentos técnicos que o Brasil produziu referente à febre amarela, que tem alguma relação com a febre amarela. Nós temos nosso guia de vigilância, o guia de vigilância entomológica e a identificação de primatas não humanos com febre amarela, o plano de contingência, o protocolo clínico e o guia de vigilância de eventos adversos, de eventos supostamente atribuídos à vacinação. Next, please. Então, eu gostaria de agradecer pela oportunidade e eu queria terminar minha apresentação fazendo alguns agradecimentos. Eu queria agradecer muito a Lívia e o Daniel. A Lívia é coordenadora de arbovirose, da vigilância de arbovirose do nosso país, e o Daniel é o técnico responsável pela vigilância de febre amarela. Eu queria fazer um agradecimento especial a eles dois. Eu queria também agradecer a Organização Pan-Americana de Saúde, que foi sempre uma grande parceira do nosso país, não apenas na vigilância de febre amarela, mas também em todo o processo de implementação do microplanejamento. E para nós, participar desse evento é uma grande honra, porque para nós é muito importante trocar experiência com os outros países. Sabemos que muitos aqui passam por momentos delicados com relação à febre amarela e passam por situações muitas vezes diferentes da nossa. Então, a gente tem muito interesse em ter conhecimento e conseguir conhecimento a partir da experiência de vocês e, ao mesmo tempo, nós estamos abertos para contribuir com o que nós acumulamos de conhecimento com vocês. Então, o Brasil ele se encontra aberto para estabelecer parcerias e trocas de experiência. Thank you very much.
Thank you so much, Ed, for a very well-rounded presentation going through the EBI and also all of the plans that have been put in place to help respond and perhaps get ahead of the yellow fever outbreaks. Overall, I just want to provide a quick summary that we've had a very productive day. We started off with work groups and special sessions, that really kind of set the stage and got people starting to get engaged in our whole discussion for the next couple of days. Then we moved on to some welcoming statements from both the government of Ethiopia showing their commitment to roll out the eye strategy and introduce yellow fever vaccine, but also from UNICEF speaking about the partnerships that we have and need to continue to strengthen to ensure that we can lower the risk of yellow fever epidemics. Then finally, we received some updates on the eye strategy from Laurence, and then also in the AFO and the AMRO region from our regional representatives. And finally, we just wrapped up now with the eye implementation from a high-level overview from the Secretariat, and then also from two countries' perspectives. Ironically, the two countries are probably some of the largest countries that we have in terms of vaccination needs and population. So I'd like to open it up. I wanted to get the summary out of the way because you probably want to leave, but I want to open and make sure there's time for questions for our colleagues who were on the panel and provided some very good presentations. And if you're online, please put your question in the chat. Yes, Tamari.
Thank you very much. I want to especially thank our colleagues from Brazil and the PAO for their presentation. I think one of the objectives of this meeting is for us to learn from each other. And listening to the team from Brazil and PAO, I'm comparing their presentation to us from the African region. And the reason why I'm asking this is that in 2019, we had outbreaks of people who visited one of our games reserves on 2 occasions. They went there and then went back to their different states and came down with yellow fever. And we stopped that, we didn't do anything to it. But listening to what is going on in Brazil, we should have done much more than that. And I think other African countries can begin to see that we never look at the issue of human, non-human primate, whatever it is. I think we are sitting down together. You can learn from each other and see what they did in Brazil. How did they achieve it? What contribution their own country's government did into it? And that's the same question I keep asking. We cannot begin to repeat what we're repeating in Africa. See the progress that is being made on the other side and not learn from what they have done. So I want to commend our colleagues from Brazil and PAO for this presentation. And also to tell our colleagues from where I come from that we have a lot to learn from them. How did they get their government to support what they're doing? And why are we just limiting ourselves to donors and whatever? And the things are going on in our different countries, and we're not following up. And I keep saying, remember that situation that happened in Nigeria on 2 separate occasions. This people visited the Games Reserve and then went back to their different states and came down with yellow fever. And we just stopped at that. And I thought that was the beginning of something that we'll have seen in Brazil. Thank you, Brazil. Thank you, Pao. Africa, thank you also, but you know what I'm saying.
As always, Tamari can provide some thought-provoking words. I see a question on the other side of the room. Yes, you have your hand raised. Sorry.
Oui, merci aux collègues qui ont eu à présenter. J'ai juste une question pour le collègue du ministère de la Santé de l'Éthiopie. Dans sa présentation, j'ai compris que l'Éthiopie ne fait pas la vaccination de routine contre la fièvre jaune. Mais j'ai vu que les couvertures vaccinales sont presque les mêmes qu'on a aussi dans les autres pays africains qui font la vaccination de routine. Je voulais savoir comment est-ce qu'ils ont fait. Comment est-ce qu'ils ont fait pour avoir ce niveau de couverture? Et quelle est la raison pour laquelle jusqu'à maintenant ils n'ont pas introduit la vaccination de routine contre la fièvre jaune? Merci.
Thank you. I missed some of your pointers during adjust my translation device. But what I can understand from your last question is we are appreciating the coverage, and you were saying that it's almost similar to other African countries, and you want to understand how you make this coverage, and what is the reason for the delay to introduce yellow fever vaccination. If I'm correct, I can proceed. Okay, thank you. So from our understanding, our coverage is suboptimal, and we believe that we need to go further, because how much is expected to eliminate or eradicate or control each targeted disease. So based on that, when we see our coverage, it's not as expected actually. But we are still appreciating our efforts and the progresses, and we are preparing ourselves to more achievements. So if you see the data from different data sources, the coverage, the administration coverage shows high actually. The way how we calculate the administration coverage is, Ethiopia has an old population census. It was conducted in 2007, and we're still using that projection, and our population and target is below expected. And you can see that the country estimate and the UN estimate is very different. Our estimate is about 109 million, but the UN estimate says that it is near to almost 130 million population. So when you calculate the target, there is a denominator issue. So that's why I think our admin report is high. But when we try to validate through other surveys, it's low. Even you can check that the WINIC, the estimate shows that the PINTAS is 65%. So it's not high for us, and we want to improve that. But regarding to the yellow fever introduction, as I tried to mention, it is recognized that it is a priority, and it's included in our strategic documents to be introduced in 2019, and then what happened globally, and specific to the country context, there were specific challenges in the country. Most of the health facilities were, fragile due to the conflicts in the country, and there was also some displacements due to drought. And the government was working entirely on restoration of the primary healthcare service, including the immunization. So since 2019, there is a 6% backslide based on the surveys of immunization coverage, for example. So our objective, our priority becomes, restoring the system. Even we want to introduce by this time, the health system was not capable to hand over additional, new vaccine introduction like the yellow fever. It is high target, as you can see from my presentation. So we are, looking for our, we are capacitating our operational capacity. Then I think this is the right time to introduce, but still we are looking for additional supporters. I think this clarifies your question. Thank you.
I'm going to turn it over to Pedro for one quick last question because we are going to get kicked out of the building pretty soon. So really quick.
To me?
Yeah.
Very quick to Gan. Gan, what are the more difficult to improve the eye that you, in your experience, do you think that is occurring that for implementation of the whole strategy of the eye?
Okay, thank you for this question. If I have interpreted you correctly, you want to know what are the most critical challenges to successful implementation of the eye strategy. So I would say from my assessment of the midterm evaluations recommendations, because the evaluation tried to look into some of these challenges and provide recommendations, I think I would want to go to the recommendation on resources, which I would say is a recurring challenge even our colleagues at every level have pointed to. So be it from a technical to a financial to a complementary standpoint, I would say there's a problem of challenges. Even at the level of the eye secretariat, we have these human and financial resource challenges, and I could cut across our core partner agencies, our government stakeholders, and so on and so forth. That is one of the key challenges, I would say, resources. And I think you have recommendations like the integration recommendation, which tries to push us to leverage as much synergies as possible to maximize impact with the limited resources we have available. So I think that could be a potential solution to that. In addition to that, there is a very strong push from these recommendations for us to engage in consolidated and joint resource mobilization activities.
Yes, I think because you have the outlook and the output, and then the activities always planned. It's very good, but no works completely.
So it's not that no work is completed. Actually, there are a lot of activities that have been launched across the eye governance framework. So you have the leadership group, which is at the top. You have the program management group. You have the secretariat, and then you have 4 technical working groups. For example, the vaccine delivery working group is called by Cassandra from Gavi, and you have Kola over there, and they lead a lot of the activities that have to do with vaccine delivery. So there's a lot that has been ongoing, and you would see this as some key components from this midterm evaluation recommendation. There is a lot around immunity gap analysis and so on and so forth. So a lot is being implemented, but there is more that needs to be done.
And where is the bottleneck is to establish the activities or between the outlook, the outcomes and the outputs?
So I wouldn't say you have bottlenecks at that level. So we have clearly defined priority areas, clearly defined expected outcomes and outputs. But in order to achieve those outputs, we need to, I would say, further brainstorm, plan, and implement activities. The other thing is that a good number of those outputs are either incremental in nature, which means you will need to attain a certain milestone before you can define further. For example, the Ethiopia Gavi application, needs to be submitted. You have key challenges, resource mobilization being one of them. If that issue is resolved, an application would be submitted. If the application is submitted, there's going to be a review by the Gavi Independent Review Committee, which may result in a recommendation for endorsement. If it is endorsed, those resources will have to be released. Then there would have to be micro-planning, there would have to be implementation, and so it cuts across multiple years. So I would say it is more of it's an incremental process in itself, and at this level, at least, I would say they are focal persons across the partnership to move those areas forward, but gaps still persist.
Thank you, gentlemen, and Key will kill me if I don't turn it over to her for some last statements.
Well, I think first of all, we'd like to thank Erin for her excellent chairing of the agenda this afternoon. Thank you so much. I'd like to thank our interpretation teams who have worked in some challenging circumstances today. We'll try and make those easier for you tomorrow. A few announcements before you leave. For our colleagues who are fasting, please don't forget to take your dinner boxes home, and I wish you a pleasant iftar this evening. Thank you to those of you who have signed up to go to your Abyssinia tomorrow evening. For those of you who would still like to go, please grab me before you leave so I can put your name on the list. The risk analysis working group will now be taking place in the WHO building because we're being kicked out of here. So come and speak to Joao if you need to be involved in that. And Laurence, just over to you for a final word for today, and then we can let everybody go.
Thanks. I don't think there's much to add really beside my appreciation for all the interventions and really with emphasis on the engagement of Ethiopia. And the honor and pleasure it's been to have Dr. Emanuela with us to open the meeting today. Thank you all for your contributions and the active engagement. It's really is a pleasure to learn from everyone. And again, this meeting is yours to enrich and shape. So do not be shy. We look forward to your input. And thanks again, Erin, for the chairing today, just after deboarding a very long flight from the US. Thank you very much.
Thanks, everyone. We'll see you back here at 8:30 tomorrow. Take care. Have a good evening.